Yes, yeah.
Where is
Vikram, you have
Vikram?
to
Not
join.
joined?
And last time's 2 case presentation by
Yeah,
Neha
yeah.
and Rohan will be there, followed by
Yeah.
Jagtap sir's presentation.
If
Yeah,
if time permits, I'm a very short case. Yeah.
Mukesh,
Hmm.
Vikram is still not there. His talk is second.
Yeah, he is just connecting right now.
Yeah, yeah, sure, sure.
Okay.
We have some time. He
Are we
must
live?
be.
Hi, Dr. Amit.
Namaste, sir. Namaste,
Namaste,
Swanim.
namaste.
So we are
Contact.
live.
Namaste, Sundar.
Hi,
Yes.
Amit.
Live. Samantha
Busy on,
sir.
busy on Sunday.
Okay.
We are
So,
live. Dr.
welcome.
Samantha, we are live. Please
Yeah, yeah.
take
So,
over. Yeah, thank you.
I welcome everybody on this podium, and also all the members, those who have joined from both from India, and also my dear colleagues and friends and seniors from Nepal. So today we'll be having the 111th webinar from the IAS. Okay. So this webinar is on advanced rotator cuff issues. Primarily, we had the meeting on the basic cuff. Today we'll be having the advanced cuff. So I will request my dear friend who is the Joint Secretary and Treasurer Sundar to have a welcome note. And also I will request Dr. Amit and Isar sir to have a welcome note. Then we'll go to the scientific meeting. Okay. So dear Sundar.
Hi, Samantha. Thank you. I mean, I think it's a great opportunity to meet some new friends. I mean, of course, I know most of you, and it's a great opportunity to share with the Nepal friends. So I ask Mukesh to proceed.
Neha, please.
Yeah. Good afternoon, everybody. Again, a huge welcome from Nagpur. It's a part 2 of the extended part of our rotator cuff session. Last week we covered basic rotator cuff diseases. Today we'll be covering advanced rotator cuff diseases. And I would like to invite our first speaker who will be speaking on double row repair. First speaker is Dr. Amit Joshi sir from Nepal.
So, am I audible and visible, please?
Yes, sir. Yes.
Yes, you are. Okay.
Thank you very much. At the very outset, I'd like to thank Arthroscopy Society of Nagpur for being a bridge between the Indian Arthroscopy Society and Arthroscopy Society of Nepal. And then it's really an honor if you see Nepal's progress over the last 5 years in arthroscopy, and then Indian Arthroscopy Society has a major role in it by training our colleague, by providing us the opportunity to discuss in such an august forum. So today I'm going to talk about the double row cuff repair. I'm not expert of double row cuff repair, but whatever I do, I usually do a double row cuff repair. I'll talk about my opinion on double row. If you look at the incidence of a rotator cuff tear, which dramatically increases, this is a paper from 2013 by a group of Easy Toy, it dramatically increases after 50 years of age. But in Nepal, I don't know, it must be the same in India as well. These rotator cuffs are most commonly neglected injuries because this occurs mostly on the senior citizens. And the commonest presentation of rotator cuff tear is a shoulder pain. And usually they are diagnosed as a frozen shoulder and commonly treated conservatively. And very rarely this patient comes to an arthroscopic surgeon. This misconception of conservative management of rotator cuff is there not only in the patients and the physiotherapists, but it's also in the doctors. If you see this publication, which is in 2017, also says that there is no difference in outcome between surgically and the conservatively treated patient. This is a 2017 paper. This is again one of the relative newer paper, again discouraging paper, which says that there is about 20 to 50% risk of failure of rotator cuff. Probably this is the reason why the general orthopedic surgeon, they do not tend to suggest surgery. But we have to understand why this failure occurs. This failure is basically a multi-regional failure. The most important is the tissue quality. The double row is basically on the suture strength, which is very, very important. We have to provide a healing environment, and till the cuff heals into the bone, we have to provide adequate stability. So when we talk about rotator cuff tear, we are talking about a tendon to bone healing, which we know that this is very, very tedious and very weak healing process. For that, we need to have a good vascular environment. We have to have a tension-free repair. And then we have to achieve probably a wider area of healing so that healing takes place faster. And during this healing, probably we need to have a stable fixation. And for this, we all know that there are two methods. One is the single row repair and the double row repair. If you look at the anatomy, the footprint is of the rotator cuff tear is not point contact. This is a wide footprint. So probably a double row more forms the anatomic reconstruction. If you see this paper, although a little older one published in 2009, but all these paper which has been quoted by this research says that double row better at footprint restoration in all the studies that has been published. Look at what happens if it is a single row repair. So when you do a single row repair, initially it may look very good, but when you start mobilizing, there is not much of stability. And if the repair is not stable, probably you have to immobilize for a longer time. So you run a risk of stiffness, and there is a chances of failure at this point. In case of double row, so when you tie with the medial row, then take the thread into the lateral side and form a lateral row reconstruction, usually with a footprint anchor. Then what happens? The flap of this, the flap of the rotator cuff is very much pressed to the footprint. So your footprint is wide, and your footprint is wide and fixation is stable. So you can allow early range of motion, and then there is a possibility of the healing. There are various methods of double row repair. I'll not go into detail of that, but the one that I practice is the transosseous equivalent. I'll show you a 2 minutes video of this. This was a 54-year-old lady with this kind of presentation. Again, she was treated for about 4 or 5 months with the diagnosis of frozen shoulder, and this is how her MRI looked like. So this is her arthroscopic video. I am very aggressive to the biceps, so most of the time I reduce bicep. It will be interesting to listen how other people manage the biceps, but I am very aggressive to the biceps. So once the bicep tenotomy is done, I do a subacromial scopy. In this case, it was a U-shaped tear, but it was a laminar tear. It is important to identify the extent of the tear, which is very, very essential for the repair process, and also the reducibility. So if your tear is very much reducible, probably you don't need to do much of release. If it is irreducible, then there are so many varieties of procedure that you have to do. To improve the vascularity on the bed of the humeral head, I do a little bit of debridement and decortication. It is not true decortication. I do not use a burr, but I use a shaver just to decorticate. A gentle release if it is required or if the reduction is in tension. Then I mark my entry portal for the medial row. Usually I use a doubly loaded 2 suture. Then I make a crimson duvet with the same tab, and then pass 2 screw to infix, and then take out all these sutures one by one above the rotator cuff into the subacromial space. So these are the process. All the 8 limbs of doubly loaded 2 suture anchors has to come out, and probably it has to be spaced adequately in equal distance, not less than 5 millimeter. So once you get it, all the sutures above the rotator cuff, then I tie. There are controversy either to make a knot here or not, but I make a very loose knot over the rotator cuff, and then take one limb from each of these knots as a lateral row. So here I'm releasing the greater trochanter, the lateral aspect of the humeral head. Take each limb from all the knots, and I use a 2 lateral row anchors. So this is 1 lateral row anchor, and then you put another lateral row anchor. If you see this reconstruction at the end, this looks beautiful and very good footprint contract and a very good compression at the footprint of the rotator cuff. However, if you see literature, what they have to say when they compare double row with a single row, there is basically no difference in the functional outcome. Whatever you do, either you do a double row or you do a single row. But it is important to know that the failure rate, although some papers say that the failure rate is not different, but majority of the paper, they say that the failure rate of the double row is significantly lower compared to a single row. However, if you see this animation, the single row fails with a type 1 failure. That means it fails from the bone to the tendon attachment at the repair site. So this is type 1 failure. If you see the double row, that fails from the tendon. So the repair site is intact, but it fails from the tendon. Probably revision of a type 2 repair is more challenging and difficult compared to a repair of a type 1 failure. This is the only thing that hinders my approach to the double row, and I make sure that the tendon quality is good before I do a double row repair. So to conclude, whenever possible, I always do a double row repair for the rotator cuff. Thank you very much.
Thank you, Dr. Amit. Thank you for your nice presentation. It was a really excellent video.
Thank you.
Excellent edited video, and it's really, really good. Nice to see.
Thank you very much.
My friend, Dr. Jagtap can tell us whether we will take the questions now, or I think we can take a few questions after each talk.
Yeah,
sure.
we can take it.
So, are there any questions for Dr. Amit on double row repair?
Dr. Amit, do you use a pump for cuff repair?
No, I do not use pump. I use the gravity,
Assisted.
Yes, I do not use pump because to do a double row, it takes a little longer time for me, unlike my colleagues. So I depend on gravity flow rather than pump.
And lateral position.
Lateral decubitus, yes.
Okay. I think Vikram is using pump. Dr. Vikram, you use pump regularly?
Yeah.
Last time we had discussion that almost now nobody is using pump. So what is your take on pump?
I always use pump for cuff.
Okay.
I think this type 2 failure for double row is because of knot tying, as mentioned by Prashant also. Of late, I have stopped taking the knots and I directly take a bite and put a lateral row anchors. Don't take middle row bites. So what's the say of other guys, other panelists on this? Are they doing the same, or everyone is taking a knot? Dr. Vishal and our colleagues from Nagpur and
Dr.
Nepal,
Sundar,
Dr. Samantha and Sundar Rajan.
We are not taking knots. We aren't taking knots. Dr. Samantha?
Yes.
Are you taking knots at the medial?
I take knots, but it's a very loose knot. Problem is that I cannot talk today because some repair work is going up, a lot of background noise. That's why I'm keeping myself mute.
Okay.
Dr. Vishal, are you there?
I think there are no such study, comparing directly randomized controlled trial on putting knot and not putting knot with the type 2 failure. But theoretically speaking, when you tie the knot, strangulate the vascularity, and then there is a possibility of this thing. But if you compare those people who are doing unknotted on the medial row, they will find out that the compression that you achieve, compression of the rotator cuff into the footprint is not that much with the non-knot tying technique.
It is there, Dr. Amit, and now with the available implants of tape instead of fiber wire, now they are tapes. So that also gives a good compression. Provided you take a bite, at the distance between the two bites should not be much.
I think
not taking the knots,
not compression but cutout. We have a lot of modification. If the tissue is not good, then you put a mesh and Allen for the fiber wire. But the tape, the advantage of tape is not that it provides compression, but the advantage is the cutout is lesser with with the tape. I think Bikram, you want to add something to that? That is my
middle path could be you place few knots and few don't put knots in all the sutures. Take few knots, and especially I take knots for the apex reduction. Like L-shaped tear at the apex, you reduce it and tie the knot there. And rest of the cuff can be done knotless. So for apex reduction, yes, knot is required. I think.
Absolutely.
Satish, you had something to say?
Yes, not taking the knots create a iatrogenic pasta lesion.
True.
The footprint won't get reduced at the medial part of the greater tuberosity. So you always have to take the knots. But if you want to avoid the type 2 tears, you take a minimum knots, one in the center, one anteriorly, and one posteriorly. You should not make the knots on each and every sutures. You take 3 knots, one anterior, one center, and one posterior. But you have to take the knots in the medial part of the curve. Because if you don't take the knots and you go intra-articular, you will see that the cuff will be looked very well reduced in the subacromial space. But when you go intra-articular, you see that the cuff on the medial edge of the footprint is quietly lifted up. So it's an accidental pasta lesion. You have to take the knots.
Sorry to disagree
you have
with
to take the minimum knots.
No,
Yes,
no.
It will
Mukesh,
depend on the anchor,
even
lateral row anchor which is used.
Yeah, Prashant, please go ahead.
If we use good quality anchor and if we tie all the threads, tighten all the threads, then there will not be any laxity on the medial side.
The issue of lift off of the medial cuff with non-tying is not there, provided you take, suppose it's a lesion where you ideally need to take 2 medial row anchors and 8 bites, but due to paucity of your economic status, if you try to take only 1 anchor, then that issue will always be there. So ideally you need 2 anchors, 8 bites at equidistance, then you won't have that issue of lift off, and there will be no iatrogenic pasta lesion. Even if you go in and see after every cuff repair, which I routinely do, it's a very well reduced cuff, and definitely there are no chances of strangulation and type 2 tear, because that is a disaster. If you have type 2 tear, then you have nothing to repair there, because it's at a muscular tendinous junction.
Okay. Sundar, what is your take? Sundar? Dr. Sundar, what is your take?
I do the knotting still, even though I use 2 or 3 medial row anchors along with the lateral row anchors. So I think all the bites which you take for the medial row, it's not in the musculocutaneous junction. Unless you have the short cuff, short females, sometimes you tend to get that much, you go close to the musculotendinous junction. Otherwise, you don't need to go that much medial to take a bite. The mistake may take that if you go and take bites over the musculotendinous junction. So you have to be very careful when you take a bite that you are taking in the good tendinous portion, which requires only to cover the footprint. If you go too medial, then that problem comes. The second issue will be, if you do on the lateral ankle in the old age patient, the bone is very osteoporotic. If you just, even though you do a non-knotting technique, sometimes I tend to put the knot on the medial rows to get a double security, so that even an osteoporotic bone that even lateral row failures with the medial row anchor holds very well with the knots. So still I tend to go with knotting, as I suggested by other guys. If the old degenerative tears, you make sure that the knot is not very tight, you don't strangulate the cuff. But in young patients, I don't think there is a big issue into failure of the type 2.
I think
yes, Dr.
I think we are solely blaming on the knot on the medial row. Probably the tightness of the repair also helps on having a type 2. If your repair is tight, very tight, probably and then you do a double row repair. So whenever your repair is not good enough or it is very tight, probably you have to refrain from doing a double row. So it is not only the knot, it is the tightness of the rotator cuff also contribute to the type 2.
I absolutely agree. The tension of the graft is very important.
Tension.
If you think that tension is too much, do medialize the cuff, just do a single row. It doesn't mean that you have to do all the time double row repair. Yes. The tension of the repair is very, very important.
Vikram will cover that releases in his next talk.
Okay.
It is most important.
very nice discussion, everybody. So heading now to our next talk, which is by Dr. Vikram Sapre, an eminent arthroscopy surgeon from Nagpur. He'll be speaking on getting back the massive rotator cuff tear.
Ismash.
Please share your screen.
Yeah.
Not yet shared, Vikram.
Okay. There's some privacy issues here. Just a minute. Yeah.
Yeah, it's visible.
Yeah, it's visible.
Okay, so good afternoon, everyone. I'm Dr. Vikram Sapre, arthroscopy surgeon from Nagpur. First of all, I would like to thank Arthroscopy Society of Nepal, Indian Arthroscopy Society, and our own Arthroscopy Society of Nagpur for having such a nice, wonderful academic collaboration, and also giving us an opportunity to share our thoughts. So coming to the massive rotator cuff tears, getting back the massive cuff tear, there is no clear-cut definition of a massive cuff tear, but by any loose definition, it is a complete tear of two tendons. So the two tendons should be completely involved. Complete tear should be there to call it as a massive cuff tear, or a tear which is more than 5 centimeters from anterior to posterior. So how are these massive cuff different? We need to have more anchor placement, more suture will be there, and the tear geometry has to be clearly identified and repair accordingly. And the cuff releases may have to be extensive here in case of retracted massive cuff tears. And the variability of the repair sequence, we need to repair it as per the type of tear. Suture management definitely will be more difficult, more cumbersome, because of number of sutures are more here. And tendon to tendon repair, like a margin convergence or an apex reduction, might have to be done here. And muscle quality, I think, nowhere else is more important than in massive cuff tears, because the complete healing depends upon the type of the muscle and ultimate outcome. So I think pre-op evaluation, we need to do a proper clinical X-ray and MRI evaluation to assess the chronicity of the tear, whether it's traumatic, atraumatic, range of motion, the strength, whether this is a pseudoparalysis, or how is the biceps and AC joint. On X-ray, we assess acromial spur, proximal migration, arthrosis, the bone quality, which may be required for a type of anchor we choose, and definitely size, retraction, and atrophy. I think most of this we have covered in our last webinar, so I will quickly skip this just to share the documentation form pre-op and post-op that we use. We identify what are the patient's complaints, we note down the clinical findings, CT and MRI findings, and post-operatively we note down the final diagnosis procedure and exact arthroscoping findings of each and every part of shoulder, and the pictorial depiction of what was torn, what was done, and number of anchors or type of anchor placement that we have done. Just a short about the checklist that we have made before going to a massive cuff tear. We need to know what's the duration, whether this is acute or chronic, traumatic or atraumatic, or a degenerative one. What's the size of the tear? What are the tendons involved? One tendon, two tendon, or complete tear is there. And the amount of retraction, whether it is retracted till humeral head or the glenoid. Additionally, we need to know proximal migration, if it is there. How's the condition of AC joint? Are there any cystic changes in the GT which may differ our plan to put an anchor? And since I use a beach chair position, medical issues, any associated, and fitness need to be known. And once we have completed all this, we are pretty much clear what type of implants we might require and other instruments which might need for this cuff repair. So that's just a checklist. Coming to the
Surgery per se, I prefer a beach chair position. One, it gives adequate internal rotation and external rotation so that I can see the tear end on. Secondly, by beach chair, I don't have to put a continuous traction, so I'm not worried about the traction time. And especially for subscap, I feel this position helps me a lot. Portal placement, my portal placement, they are the standard portal, posterior portal, which is 1.5 centimeter inferior and medial to lateral angle, posterior angle of acromion. The lateral edge of acromion, I divide it into 3 parts, and the lateral portal is at the junction of anterior third and middle third, and around 2.5 centimeter lateral to inferior to it. The posterior lateral portal, which is my main viewing portal, is around a centimeter inferior at the junction of middle and posterior third of the lateral edge of acromion. Anterior portals are anterior superior and commonly anterior inferior. Anterior superior portal is just anterior inferior to the AC joint. So these are the commonly used portals, but we should not be limited to these all limited named portals. We can additionally have portals for traction suture or for putting anchors. So we are not, we should not remain limited to these named portals. Coming to the getting the cuff back, we need to go a stepwise and complete all the releases which are required for a complete cuff reduction. So this is like any other trauma situation where it's an old trauma and when you need to get a complete reduction. So you need to have some extensive releases. So step 1 is an intra-articular release where we deal with if there is any subscap pathology, tear, retraction, biceps. If it's a retracted subscap, we might have to go with a triple release or a 270-degree release for subscap and then repair it finally. Biceps tenotomy, tenodesis, and coracohumeral ligament release. Step 2, once we have done our intra-articular work, we move on to the subacromial space where we do basic releases or the bursal release, which we might have to require to do in any other type of cuff tear. And acromioplasty. Generally, in massive cuff tear, we are not very aggressive with acromioplasty because CA ligament might prevent proximal humeral migration. Step 3 is assessment of cuff tear pattern and reducibility. We need to assess how the cuff tear is, what type of tear it is, and how much it is reducible. If it's not receding, then we might have to excavate the cuff. By excavating, we mean we take off the adhesions. It's a sort of adhesiolysis of the cuff from the acromion, from the posterior deltoid fascia, lateral gutter, and anterior side. So lysing the adhesions from the deltoid and acromion. Then we might, if still not coming, we might have to do a capsular release. And if all this not meet, then we might have to do an advanced release or the interval releases. We'll see in detail one by one. So intra-articular pathology, subscap and biceps. So this was a left shoulder of a 60-year-old male. This was a traumatic. As soon as we entered the joint, we saw this retracted tear. You have to fish it out to see the subscap tendon. So we are pretty clear we need to do an extensive release to get back this subscapularis. So here we start doing it with a biceps tenotomy. This was an unstable biceps. So, and a complete subscap tear. And once we do a tenotomy, you can do tenotomy or a tenodesis depending upon the patient and other preferences. Once tenotomy is done, we move on to subscap release. Identify the comma tissue. This is the comma tissue that's there. The best possible way is give a traction stitch along the reduction line. So this is the traction stitch we have taken, rotator interval release. Then this is the anterior release that we are doing it, releasing the subscap from the anterior adhesions. Once these anterior releases are done, then we move on to posterior releases, the adhesions between the subscap and the glenoid maybe. Can take down the MGHL. And once this is done, we remove all the debris because we might have to sutures and all will be there. And then the debridement of the subscap footprint. Once that is done, we do final subscap repair. 1 or 2 anchors may be required for subscap repair. I generally prefer a crochet type of repair, wherein I take one mattress suture and one simple stitch. Can use the direct or indirect instruments, retrograde or antigrade type of instruments for a suture passage or suture shuttle. And once this is done, this is a sort of a Mason-Allen type of stitch. And once that is done, repair is done and the subscap is done. Just to mention about the importance of coracohumeral ligament release, I think this part was very well covered in anatomy part in the last webinar. The layer 1 and layer 4 of the cuff is the deeper superficial and deep extension of coracohumeral ligament. So when there are adhesions in the coracohumeral ligament, they are going to they will be accompanied by rotator interval adhesions. So these need to be taken down for to increase the cuff mobility from the undersurface of coracoid. So once we are done with the intra-articular work, rotator interval release, subscapularis and biceps management, then we move on to subacromial space, wherein we first identify the anterior border of acromion. We do acromioplasty only if there is obvious a spur out there. Once we delineate the spur, only then a gentle acromioplasty is done. We do not go very aggressive in case of massive cuff tears. We just remove the small spur that is there with the burr. So once we are over with there, we do the bursal releases. These are the simple releases that we may require for any other cuff tear. This is just like a bursectomy and improving the vision for our further repair and suture management. So the bursal releases, this is on the medial side. The visualizing portal is posterolateral and working through lateral portal. Then remove these adhesions as well, so that it will increase further mobility of the cuff. Then as we go to the posterior, we might have to remove the posterior curtain or the adhesions that are there. These adhesions will decrease our vision here. So these adhesions need to go. Then you enter through a posterior portal and remove the fibrofatty tissue which lies between the posterior cuff and the deltoid, and remove all the debris so that our suture passage bites that we take from here will be visible and will not be lost. Then you clear the lateral gutter as well. The extent is from anterior. You can see the biceps there. Yeah. So from there to till the posterior end of the cuff tear, we clear the lateral gutter for our lateral row anchors. So once we are done with this and still the cuff is not completely reducing, we need to do further more adhesive lysis or releases, which you call as cuff excavation. So it is basically the adhesive lysis of the cuff adhesions to the acromion, the superiorly, and the deltoid fascia, which is posteriorly near the infraspinatus, and the laterally where we put our lateral row anchors, and anteriorly. So all these adhesions need to be removed. The traction suture is very helpful, and I prefer to use a traction suture in line with the apex of the tear. So it could be for L or reverse L at the apex, and for crescent tear it could be at the center of it, and pull the traction, give the traction along the line of reduction, which will help us and see the adhesions which are present and will help us to release that. Once we are done with that, adequate releases we are done, then we assess the tear pattern. We see the mediolateral mobility of the cuff as well as antero-posterior mobility. We can change the portals for doing both this, or we can see from the same portal also. So in this, we are getting more posterior to anterior mobility as compared to medial lateral mobility, probably a reverse L type of tear. So once we have assessed the tear, we define it the tear, whether this is elliptical tear or a crescent shape of tear in which the medial lateral mobility is more as compared to anteroposterior mobility. In the reverse L shape of tear, we have more posterior to anterior mobility as compared to medial lateral mobility, and L-shaped tear we have more posterior to anterior to posterior mobility as compared to medial lateral mobility. The principle that we follow for the reverse LL is, these are basically the apex is anterior or posterior. We generally reduce the apex of those tears, and then a final reduction is assessed and fixation is done. If we are not getting adequate releases, we can further release it by capsular release. By doing a capsular release, we might achieve 1 to 1.5 centimeters more of reducibility, but this will not convert a irreducible tear into a reducible tear. So how we do it? We start from the rotator interval and go from anterior to posterior between the labrum and the cuff. A complete release is required. You can see the remnants of a capsule out there. So all these need to go, and you should be able to see the muscle also. That is the endpoint of this. A word of caution in this release is don't go more than 1.5 to 2 centimeters medially, where you may encounter on the posterior side suprascapular nerve, or there could be bleeding issues which will be difficult to control. So the cuff repair, the method which we prefer is knotless double row if we can achieve a complete reduction, proper reduction if we are able to achieve. Single row if it comes till the edge only. We prefer 2 or 3 medial row anchors, or a double, or we prefer double row, or a triple row loaded also can be used. Apex reduction stitch is a preferable for L or reverse L tears. Here is the point where I take a triple loaded anchor, so that one suture you can do a apex reduction, and rest you can be done for knotless repair. And visualizing portal, we always keep it on the posterolateral portal to see the cuff end on. So like this was a cuff tear. A massive cuff tear from anterior to the complete posterior. This was a traumatic tear. First we go with a posterior anchor. I prefer 2 threads in one bite, so that we decrease the number of bites in the cuff. That's the second bite. So these 2 sutures will go with 1 bite. Then the anterior anchor. And from here also, we take 2 sutures. I generally prefer lasso type of instrument. And then after reduction, we go on the lateral side, 2 lateral row anchors. And here we get a complete reduction of the tear. So the other thing is margin convergence. Margin convergence, the idea behind margin convergence is it reduces the tension. Commonly, it is utilized for a deep U-shaped type of tear in which a tendon to tendon type of repair can be done. The advantage it offers is it reduces the tension on the final repair. So this can be done. For L-shaped tear, what I described was like an apex reduction. You take 1 stitch there as shown in the diagram, and then complete the rest of the cuff, medial to lateral repair. Like this is the margin convergence which we have taken, or the apex reduction. The couple of stitches are placed at the apex, and the blue thread can be used for the double row repair. Coming to the most advanced release, or the interval release, we can do anterior interval release. That's the interval between subscap and supraspinatus, and the posterior interval release, which is between supraspinatus and infraspinatus. As far as possible, most of the literature that is, they do not advise for a posterior interval release. Anterior interval release can still be done, but the posterior interval slides, they do not improve cuff healing. The other disadvantages, it leads to weakness of the muscle, as well as it can also lead to suprascapular nerve palsy, because there will be a significant amount of traction and stretch produced because of release of the posterior interval. So not much advised. This was a paper in JBJS in 2013, in which by Kim, in which they have said a short-term follow-up, a complete repair of large to massive contracted rotator cuff tears with an aggressive release, such as a posterior interval slide, may not have the desired benefit as compared with partial repair without a posterior interval slide. So they are comparing, like they are saying a better would be a partial repair than doing a posterior interval slide. Coming to the partial repair, the most of the studies regarding partial repair, if you see the concept of the partial repair, it is the balancing the force couple, anterior force couple and the posterior force couples. The mid part of the cuff, which may not be repairable, can be left alone, and only the anterior and posterior are repaired. If anterior is intact, then only posterior superior cuff needs to be repaired. The advantage it offers is, in most of the studies on the partial cuff, which I have seen, they have shown a good outcome. Though they do not restore the complete strength, most patients, they say they are satisfied with overall improvement in function. So yes, partial repair may improve the function, though not a complete relief. The other way to make it repairable is a medialization of footprint. Footprint medialization can be done with ring curette. We can go in a measured way with the ring curette. The ideal amount is around 5 to 8 millimeter. You can go by size of a ring curette. We can go and repair slightly medially. So the medialized repair, in most of the studies, they are showing a good outcome. This was a paper from JSES in which by Kim, in which we concluded that medialized repair may be useful in cases in which anatomical bone to tendon repair would be difficult because of excessive tension of repaired tendon and torn tendon that does not reach the anatomic insertion. The other one is by Von Lee, in which they have said the clinical outcome of arthroscopic partial repairs of large to massive posterior rotator cuff tears. In the medialized cuff repair, the only negative factor which might be important is acromio-humeral distance less than 5.3 millimeter. If it is that much, then this might not help. Otherwise, partial repair will be useful. So coming to the conclusion, what we need is proper pre-op evaluation to assess the cuff repairability. We need to go in a stepwise manner to release and bring back that cuff. The margin convergence should be utilized, and apex reduction can help us to reduce the tension on repair and achieve a good final repair. Partial repair and medialization of repair can be done in massive contracted cuff tears. Yes, they are useful. Posterior interval slide should be avoided as far as possible. I think. Thank you very much.
Thank you, Dr. Vikram.
Thank you, Dr. Vikram. Thank you. Thank you.
So, thank you, Edward, for such a lucid presentation, Dr. Vikram. Are there any questions for Dr. Vikram? First, I would like to ask Dr. Pradhan if they have any comments. Our chairpersons, Dr. Sahani and Dr. Pradhan.
Please stop your screen sharing so that other guy can get ready.
Yeah. How to do that?
Same way you, same way you did share screen. Yeah.
I paused there.
Yeah, Dr. Vishal.
That was an excellent talk, Vikram.
Yeah, it was a brilliant talk, Vikram. I really enjoyed it, and you covered pretty much everything. My take is very simple, couple of things. One is that spend some time on releasing all the adhesions. That is very important. Don't rush. Second is, which Vikram also showed in his this thing, that always, I never use the grasper for holding the cuff from time to time and checking whether it is coming down to the footprint. I use a suture manipulator that is far more atraumatic, and you know that a tensionless in a tensionless way you can bring the cuff down. So the graspers, they actually damage the cuff a lot, and after you've done 6 or 7 times, use the graspers, they do damage the cuff, which is already, you have a poor quality cuff tissue, you don't have adequate cuff tissue, you're struggling to bring it to the footprint, and then you're damaging it further by pulling it with a grasper. So that is second. And third, most important, which I think is very often ignored, is medialization. Rather than having a very tight, tense cuff repair, I would go a bit more on medialization, and I have never regretted that in terms of clinical results as well. The only negative side of medialization is that the range of movements could be reduced, and that you are talking about terminal abduction and terminal forward flexion. That is not a huge thing to lose compared to the fact that you get a well-healed cuff which is functioning well. And also, from next time, especially for the junior surgeons who are getting into it, when you do shoulder arthroscopy, always check, take your scope right from the long head of biceps and go to the footprint slowly and check. A lot of patients, the footprint will start at about, say, 2 o'clock. In some, it will start at 3 o'clock. In some, it will start 4 o'clock. So you will realize that there is a lot of variations in the anatomy of the humeral head. Some people have a very spherical humeral head, whereas some have almost half a sphere or a bit less. So basically what you want to do is, if you see that your humeral head or the footprint is starting at 3 o'clock, then you have more area for medialization. So overall, what I want to say is, do not ignore medialization. It is a very good thing, and you do not lose a lot, but you gain a lot because you will have a good tension-free cuff repair that will heal, and that's what your main objective is.
Thank you.
Great.
Thank you, Dr. Vishal. Dr. Pradhan, would you like to comment?
Rajiv had got a question. Rajiv, yeah.
It's okay. I can wait, sir. I'll wait after the comment. Thank you, Dr. Bikram. That was an excellent presentation, very lucid, and I don't think I have much to add here. And thank you for a very nice presentation, a great learning experience.
Thank you, Dr. Rajiv.
I just had a small question for Dr. Vikram. Dr. Vikram, you talked about partial repair. What would be the actual indications, and when do we actually go in for a partial repair? And how often do you actually need to do it, and how would the rehab differ? I just had queries regarding.
So I'll tell you, when I was doing a literature review for the partial repair, medialization of the repair, and the posterior interval slide. So if you see, most of the studies, they have a good outcome, functional outcome with the medialization of the repair and partial cuff repair. Only thing is, in the partial repair, you need to balance the force couples. You should either, if it's anterior one is torn, you have to repair it, and then the posterior. The middle part can be, if it is not getting covered, if your complete reduction is not possible. But the most important thing is you have to balance the force couples for partial repair. And medialization, yes, you can do, as Dr. Sania said, it is really good, and all the outcome studies are in favor of medialization. They have good functional outcome, though they might not achieve full strength.
And the rehab protocol?
I think Amit is going to
rehab will be a slow rehab. Yes, definitely. That is the one cause of concern for a partial cuff repair. Your rehab will be actually very slow, no doubt.
Okay.
Yes,
Dr. Amit
Okay, thank you.
Dr. Amit, yeah.
and Dr. Mukesh after that.
Yes, I think release and reduction has to go simultaneously. So that is why I absolutely agree that probably if you put a stitch, reduction stitch, so you release some part and then you try to reduce it either. So if you start releasing, you don't know when to stop. And the stop point is once you get an adequate reduction. If with your extensive release, you are not able to reduce and you don't know how to reduce posteriorly or how to do an interval slide, probably you medialize your this thing. So release has to be contemplated with the reduction. You release some tissue, then you try your reduction. If it is not coming, you try. I think that has to be stopped, contemplated with each other. Bikram, would you agree with that? Or
Yeah, definitely. Release is the most important thing here. And as I've said, the traction suture, it is like holding something and trying to reduce it, and the adhesions which you see, you remove those adhesions. So those are the you will see those are the adhesions which are hindering the reduction. So you release where you actually want to release. So that is the advantage of giving a traction stitch and releasing it.
Okay. So, Dr. Mukesh, last question.
The only thing which I would like to ask in everyone, usually you encounter posterior bleeding when you do posterior curtain release. And a lot of muggy things or fibrous tissues are there. Any technical tips and tricks from all how to get a good posterior release with minimum bleeding? Because most of the time we struggle doing that. Anterior and superior release is quite easy and yeah. So Vikram and other all panelists, please.
I use cuff. I use pump.
Okay.
You use pump.
I use adrenaline also. For the whole procedure, most of the times anesthetists agree to give 6 to 8 adrenaline in each 3 liter of saline.
That's too much. Who is the anesthetist?
It's in 3 liters. No problem.
But in all bottles?
6 to 8, I said.
6 to 8 liters.
Actually, Bikram, the recommendation is 1 3-liter bottles. You can give one ampule.
Yeah.
Yes.
Maximum you can go to 3. It should be one in lakh.
It's it goes away, no sir. It doesn't get. It's for 3 liters.
No, I understand. His problem is that you have to follow the recommendation. Is that it should be 1 in lakh. This is the clinical recommendation. You can go ahead, but this has already been thrown out. But problem is the recommended idea of putting the adrenaline is 1 ampule in 1,000. 1 ampule in 1,000.
That's the
I think
it
Sundar
comes
might
up to
be
1 in 3 lakhs.
So the recommendation probably is you dilute 1 ml of adrenaline to 10 ml, and then you use 1 ml of this diluted adrenaline per 3 liters of saline bottles, so that you can use this in around 8 to 10 bottles also. Then
amounts to same.
You dilute 1 ml of adrenaline to 10 ml of 10 ml of distilled water, and then you can use 1 ml of this diluted adrenaline in 10 bottles.
And then
So the total adrenaline which is given to the patient remains the same only.
1/30th of dilution of the adrenaline.
Yeah. So that's what. So that's the reason you have been able to use so much of adrenaline in so many bottles also.
Yeah, this is
Total
what
amount
my
of adrenaline being used is
advised.
almost the same only.
And even Dr. Pancha was using when I was there in Thailand. I think
I think we should just push, with all that thing, we should push the shoulder anteriorly and give some external rotation and use your RF probe from posterior portal to clear that maximum bug and see that it's on the coag mode rather than the cutting mode. So and be careful in removing the posterior bird's curtain.
Alternatively,
in chronic cuff, they are so thick. One minute, Vikram. In chronic cuff, they are sometimes so thick you feel like as if it is a rotator cuff. So you have to be very careful in removing that curtain. Otherwise, you will catch hold of that thicker bursal tissue and repair it.
Yeah. I think. Let me add just a little bit.
Yeah.
By saying that probably if we are discussing the good visibility, good user of RF, good use of RF will replaced by the pump and the adrenaline. Probably this is not right. Probably you have to have a good visibility. Use your cautery mode and the cutting mode of the RF very judiciously when you are releasing the posterior side. And in my hand, I do not use adrenaline and pump. They are only for those very few cases reserved in which you get a very retractable bleeding. But a good visibility and use of your radio frequency ablator very judiciously will
and a friendly anesthetist.
and friendly, yes, hypotensive anesthesia.
One more thing
I do not use up adrenaline at all. I've never used adrenaline. I use the radio frequency. I do beach chair position. Once you've done one thing you realize is that there are certain areas which are very vascular, like the posterior part of the acromioclavicular joint when you go there, and the posterior medial part, and one or two areas you realize are more vascular than others. So in those areas, I always use the coag rather than the cutting, or if I use cutting, then I'm very quick, next coag, cut coag, cut coag, cut coag. So in those vascular areas, you have to probably do alternate. So don't keep cutting, and then because there is a bleeder, you lost it, it goes into the tissues and there's bleeding. So if you are using cut, release, cut, coag, and then go to the next step. So you are coagulating each step as you go forwards.
Okay.
Let's move.
Thank you.
Just 1 second. I think last time Tejas has mentioned a very good article about the vascular anatomy. Yeah, that was really
that is good. That is a good read.
Yeah, that is a good read.
Yeah. Thank you, Dr. Vikram.
Thank you, Dr. Vikram. Thank you. Nice presentation. Yeah. Thank you, Vikram. Thank you.
Yeah.
Thank you, Vikram.
Now we should move ahead, and I would like to invite Dr. Satish Sona for his next talk, utilizing the biceps in massive rotator cuff tear.
In the meantime, I welcome Dr. Bishal. Bishal, I think Dr. Bishal joined late. Hi, welcome.
Dr. Satish.
Thank you.
I think, hello, Dr. Satish?
Some net issue.
I think he is having some net issues. I think we can move on to.
So we can move on to our next talk by Dr. Sundar Rajan, which is on replacing the original cuff. Then we'll take the Dr. Satish Sona's lecture.
Can I see my screen?
Yes, yes, you can see your screen.
Okay. Good afternoon, and I take this opportunity to thank Nagpur Arthroscopic Society for giving me this opportunity to meet all of you and Nepal friends. So when Mukesh told replacing the original cuff, I was thinking in myself, how can you replace the original cuff? So hopefully I understood that it could be an irreparable cuff tear. Mukesh, so I will talk about some irreparable cuff tears, how to replace it. So I think all of you should, most of you know the definition of irreparable cuff tear, wherein it cannot be repaired primarily to the incision on the tuberosities, despite conventional techniques of surgical release and mobilization because of the size, retraction, and muscle impairment caused by atrophy and fatty infiltration. I think how to diagnose irreparable cuff is $1 million question. It is not easy to predict by clinically or even radiologically to come to the conclusion, okay, I'm going to repair this cuff in full or in partial, or I may not be able to repair. It is very, very tough to repair. However, some of the clinical, like when you patients with 3 years, 4 years with a long duration of the symptoms, when they have an extensive external rotational lag, then you may think that this may be a very, very irreparable cuff. Of course, it is supported with your radiological pictures, where when you have a superior migration, again, that may indicate that it's a very chronic cuff tear with migration, then this may not be able to repair it, which you can keep it in mind. So when you take a conclusion to diagnose irreparable cuff tear, I think it's very important that radiologically you should identify what kind of Hamada classification it comes in. I think all of us are aware that type 1 and 2 is almost like maintaining that humeral distance of 6 mm, and type 2 is less than 5 mm. So within this, then the cuff duration is not that much more, and this patient may not have arthritis. If it goes to 3, 4, 5, then you are going to the arthritic side. So we should know this Hamada classification to, especially for the management side. If we think that it is not going to be repairable, then we have to think about. Then other MRI findings which can give you a clue that this cuff may not be able to repair when the torn cuff with retraction to the glenoid or beyond the glenoid, which we are of us aware, or the fatty infiltration of the rotator cuff muscles goes more than 50%, then we know that the quality of the cuff is going to be bad, and when you pull it, it may tear it. So consider before planning management is very, very important patient's age. But however, the age and activity demand, not just age alone, it could be a physiological age. So when you decide to do some procedure for irreparable cuff tear, age alone cannot be a criteria for to do any procedure for irreparable cuff tear. So it's basically the patient what demands, what kind of activity he wants, then you decide whether this patient needs that particular surgery or not. Of course, you have to take a consideration of the all other factors which we've already decided about the muscle atrophy, tear pattern, retraction. And also we should to know the reliability and integrity of the remaining rotator cuff, especially subscapularis, because we know that the subscapularis is very, very important structure when any irreparable supra and infra, because most of the procedure rely on the supra subscapularis tendon. So it is important that subscapularis is repairable or it is intact. That is very much important whenever you deal with massive irreparable cuff tear. Of course, it's a long learning curve. Anything which manage an irreparable cuff tear, any procedure you do, this is not a very commonly done procedure. So you should have a good training and you should have a familiarity with the surgical technique before you proceed that I can manage this irreparable cuff tear. Okay, is there any role of conservative management in irreparable cuff tear? I think all of us have seen many patients with a lot of patients with complete loss of cuff tear. I mean, complete loss of cuff with good functional movements. When we see incidentally for some other finding or when you do a cervical spine MRI, they may have sometimes have a complete tear, they'll have a full range of movements. So without any problem at all, symptoms at all. So any patients with an elderly patients with their less demand, they're sedentary, they have a medical comorbidities, or if they're not willing for surgical management, definitely there is a role of conservative management. It doesn't mean that that cuff cannot be, that patients cannot be just ruled out. So physiotherapy is playing a very, very important role in these cases. We know that by doing a scapular subluxation exercises and structural deltoid rehabilitation program can help to improve the overhead abduction. So many patients will be happy if they get overhead abduction without pain. Then these patients will, that strength of the cuff may not improve, but they will get a functional range of abduction or flexion without pain. Then I think that patients will be very, very happy if you do a conservative role. There are few papers which we had seen that even the Journal of Shoulder Surgery, which was published by Levy et al. Long back, the role of anterior deltoid redirection in patients with massive cuff tears with the good results. This is a study which they had done for anterior deltoid training program, continued for 12 weeks, which they had shown that constant score had improved from 26 to 63 and improvement from 26 to 63, and forward flexion has improved from 40 to 160. That is a very, very good improvement. Or sometimes even intra-articular steroid injections can help in many patients with some studies. So we have to do partial repair. I think already the Vikram and other panelists have discussed extensively about the partial repair. I think the concept of the partial repair also had come with, like Stephen Burkhardt had said, that many patients which we see that with complete tear of a cuff, they had a good range of movements. So why can't you do a partial repair in symptomatic patients? So whenever the patients have the same tissue quality with the tendon loss, with a severe retraction, still we can do a partial repair. I think even by doing an infraspinatus repair alone, even though we talked about the force couple, which Vikram had mentioned and showed that beautiful diagram, it is in my opinion, any chronic retracted with the supra infra, it is impossible to bring it back to the supra and infra to attach on either side and leave the center back. Because many times when we see these completely retracted supra and infra, you can mobilize and bring the infraspinatus back to the footprint, but it is impossible to bring the supraspinatus in my experience. So I think the force couple principle is coming to the picture whenever there is a massive cuff tear with a reasonable duration of the symptoms. where you can bring it back and attach. In that case, maybe the force couple may work. But in chronic retracted cup tears, I don't think we can bring the supra to the footprint. So in that cases, sometimes you may repair only infraspinatus, like in this case, where even you see the more than 50% of fat infiltration and muscle atrophy, retraction up to the glenoid in this MRI. And these patients, sometimes you will be able to mobilize. We can see that supra is almost up to the biceps level or more than the glenoid, glenoid, beyond the glenoid retraction, where you do extensive glenoid soft tissue release and the bursal side release. You may bring it, you can supraspinatus, it's not possible to bring it at all. So in these cases, usually I tend to bring at least infraspinatus, so that can, in my experience, that has given a very good pain relief and a reasonable range of movements in chronic retracted cuff tear. So whenever it's possible, if you can bring a partial repair by doing an infraspinatus, I'm happy to do that repair. If it is not possible to do that also, I mean, what are the other surgical options? I think all of us are aware all these options. I think the debridement and biceps tenotomy or tenodesis also had been documented in the literature with the good results of functional range. They may not have the power, but they have a good functional range with the pain relief. Even the Rockwood et al. Had published a very good series on that. Patch augmentation and subacromial balloon, we don't practice here in India. We don't have much this, but patch augmentation has come and gone. Such still people are doing. Still we don't have much experience on that. Subacromial balloon, again, it is practiced in some part of the Turkish surgeons or few surgeons. They have claiming good results. However, we know that you should have a good subscapularis, because that can migrate anteriorly if you don't have a good supraspinatus. So we left out with the other three options which commonly practiced nowadays by any irreparable cuff tear. One is superior capsular reconstruction, tendon transfer, and reverse shoulder arthroplasty. So we talk about only these three, most of them. Just I talk about 2 slides about the biodegradable subacromial spacer, where, because as I said, it was used by few surgeons, because basically it acts as a spacer. Where these publications from the Turkey, where they claim this is less morbidity, short procedure time, and absence of postoperative rehabilitation requirement can be considered advantage of this method. In the short term, they had claimed good results. So, and also they had a good functional improvement of 84.6% in these patients. However, they said, already I said that it cannot be an option in patients with the subscapularis tears due to the risk of anterior migration of the balloon. For good outcome, for this procedure, the patient should have, patients without fixed humeral head elevation in stress x-rays or in a chronic pseudoparalysis, then this procedure may not be an ideal. When you come to the superior capsular reconstruction, we know that in the recent time we discussed much about superior capsular reconstruction after Mihata paper. I think for the junior purpose, just I want to say, what is superior capsule? Superior capsule is a thin membrane structures deep to the rotator cuff. They have a very good, almost 30% to 61% of substantial area in attachment in the greater tuberosity. So it is acting not only as a spacer, but also as a stabilizer in the glenohumeral joint. So that's why we see as a superior capsular reconstruction as a procedure, so that it stabilizes this humeral joint, glenohumeral joint, so that it improves the function by having the good deltoid. So when do you do a superior capsular reconstruction? So whenever you have massive irreparable cuff tear with the supra and infra, with the minimal or no rotator cuff arthropathy, so where you can go up to Hamada grade 1 or 2, and you should have an intact or repairable subscapularis tendon, and you should have a good functional deltoid muscle. I think this is a more important prerequisite for any superior capsular reconstruction. So any patients with intolerable pain, or if they are not improved with the conservative management, you can have an option of superior capsular reconstruction. I think we know that this paper by Mihata in 2013, where he had published with the 24 shoulders with a very good functional outcome with the facial lata patch, where all the patients had improved elevation from pre-op of 84 to 148 and no progression of osteoarthritis or cuff muscle atrophy in midterm follow-up. So basically now we have 2 options. One is the folded facial lata autograft, but where you should have at least minimum of 6 to 8 mm in the thickness to have a good results. or a dermal allograft is done with few surgeons where they have only 3 to 4 mm thickness. When you compare these two, the improved restoration of superior glenohumeral stability with the decreased subabdominal contact pressure with the use of 8 mm fasciolata graft comparing with the 4 mm dermal graft. So people are slowly doing more on with fasciolata graft, and also fasciolata graft has got a less elongation compared to the thinning than the humeral dermal allograft. This is one of the patient which I did recently on 54 years old male patient. He's a very young patient, 54, a very active patient, right shoulder pain for 1.5 years. That is the active and the passive abduction of that patient clinically, which we had done a conservative trial for 1.5 years, which knows no more further improvement. Then that is the flexion which he has got around 30 to 40 degrees. After that, you can see that he is moving the scapula, but passively almost 90 to 100 degrees with a slight stiffness over there. Of course, the rotation is not very bad. That is the X-ray of that same patient where you can see the superior migration of the humerus, but no arthritis over there, no stabilization. And you can see that in the coronal view, you can see that it is retracted beyond the at the level of the glenoid. And you can see that infraspinatus is also retracted to the same level. And you can see that in the axial view, you can see the tear of the both supra and infra, but you can see still the subscap is intact over there. So I thought it could be an ideal case because in young patients, 1.5 years, if I'm not able to do a partial repair, I will do a superior capsular reconstruction. After releasing all the bursal tissue, this view is there, but this view is not as soon as you put a scope, but after removing all the bursa, you can see some part of the infraspinatus still is there. Biceps is not very bad, but you can see that supra and part of the infra is beyond the humeral head. And this patient, first we tried to do a repair of infraspinatus with a double-loaded anchor, where the footprint was lifted off from the infraspinatus, and also we bring it back some more anterior to the original footprint and attached to the infraspinatus attachments. So still then we left it out with the part of the infraspinatus over area, and also you can see these completely supraspinatus is beyond the glenoid level. Then you take the measurement from the glenoid level. Then you take measurements in the tuberosity level by using a lasso or any other method which you can use it. Here I'm using a lasso. You take 1 centimeter more than what it comes over there. Then you have done the glenoid preparation. And using the Navier portal, you use the double-loaded 2 anchors in the glenoid level. Then this is the fasciolata which was taken and prepared around, we got it around I think around 6 mm thickness graft, and which was taken bites through the fiber wires and the tapes which was to put it on the glenoid. I didn't put the screws on the tuberosity side, worrying about these suture tanglings. So just I put only the glenoid sutures and took the fibers out and took the bites in the glenoid side of the fasciolata graft. Then you, by pulling these your fiber wires and trying to insert the graft inside by pushing with the artery forces, you make a liberal incision on the lateral portal over here, more than the 1.5 centimeter incision, because the whole thing has to go inside. Then you try to, you're seeing the arthroscopic view of the fasciolata coming inside, and you take it all along the glenoid level by pulling the both fiber wire on the both the anterior and the posterior anchors, which was on the glenoid side, which take the graft inside. Once the graft goes inside, then you tie it up on the glenoid level over there, and you can see that there was a knots which are made in the glenoid. So once you finish the glenoid level tying of the knots, then you can see that the good position of the graft on the glenoid side. So usually, as I said already, I don't put that lateral anchor earlier, but once I finish the glenoid side, then you put the anchor, then I use a scorpion to take bites through the lateral end of the graft. Here I'm using I used the 2 anchors on the lateral side for the medial row, then 2 lateral row. So that was the bites, and that was the final preparation of the final tying of the lateral row. Once I done that, then you do the repair of the whatever the infraspinatus which you have done a partial repair. It is very important that we can do the stitching of the facial attack graft to the infraspinatus. So here I am taking a 2-3 stitches through the graft to the infraspinatus, which already done a partial repair. Then that is the third bite which you have done that. And also the biceps, which was found, which I thought reasonably good, even if you're using the fascia lata, that I found that there is a small gap over there, that I thought, because many people use now biceps as a superior capsular reconstruction. So even that for that gap, I had used the biceps tendon, which I left the glenoid level intact, and do the tenotomies on this side and put it on the tuberosity side. So that gives you more cuff view. However, we should not forget about the complications of that superior capsular reconstruction. The failure rate is around 3 to 17% in the literature. When you come to the tendon transfer, again, active patients, again, I mean, what do you mean by active patients? Any patients, physiological active patients who demand only that particular action like an external rotations, I think tendon transfer is an ideal procedure. However, the indications are almost same like a superior capsular reconstruction, where Hamada 1 and 2, there should not be any arthritis. So the weakness and external rotation loss are the very important indications for any tendon transfer, especially for the posterior superior tear. I think some of you might have listened to the Bossom's literature, talk on that day. There was a very good, fantastic talk. So I think, in my opinion, I don't do many tendon transfer. I think still there is a lot of, maybe we don't tap the potential of doing a tendon transfers. And also our expectation of the patients are more of pain relief and the functional range of flexion and abduction rather than external rotation alone. So I don't know whether this patient, how many patients will be happy to do on tendon transfers alone. I think that after the Gerber had published this latissimus dorsi to the posterior superior cup tear, it became very popular, and also a pectoralis major for the anterior superior tear. And this is the pectoralis major transfer for the subscapularis tear, and the latissimus and pectoralis minor also can be transferred for the subscap tear. However, recently, after listening to the Bassam for the last 4 or 5 years, and he says that all the cuff is coming from the posterior chest, so we should not transfer from anterior to posterior, where he says that lower trapezius transfer with allograft or a hamstring graft gives very good results. And also he does the latissimus dorsi transfer to the subscap tear. So I think the patients who really demands with a more functional outcome, who require good external rotation or the good functional range without pain, I think tendon transfer still hold good. So when you do a reverse shoulder arthroplasty, I think all of us are aware that any patients with a very old comorbid factors with the less than 90 degrees of forward flexion, pseudoparalysis and pain, and any anterior superior escape of humeral head with arthritis. Very important that any abnormal function of deltoid are contraindicated for the reverse shoulder arthroplasty, with all of us aware. I think this could be an ideal indications when you have a superior migration escape with an arthritis, then these patients can ideal candidate for reverse shoulder arthroplasty. Especially for the young surgeons who wants to do a reverse arthroplasty, make sure that you have a right indication to do that. You may not end up with a lot of complications. So all of us should aware that reverse shoulder arthroplasty is not just a bread and butter. It's got a lot of complications like dislocations, fractures of the humerus and glenoid and acromial fractures, heterotropic ossification, periprosthetic fractures. And moreover, the revision of these cases are very, very tough. So choose the right patients to do a reverse shoulder arthroplasty. So when you come to the final slide, I think I told about all the options. So basically we talk about the SCR or tendon transfer, reverse shoulder arthroplasty, choose the right indications and do the right procedure. Thank you very much.
Thank you, my dear friend Sundar. Excellent talk. You have covered everything about the massive cuff. So I think if there is any question, we can take. Sundar, I have got one query and question. See, is that you showed that when you did the SCR, that you have kept the biceps anchor on the glenoid side.
Yeah.
The biceps, the origin. Okay. So do you find any difficulty when you put your 2 anchors for the SCR? Because most of the time we do like the 2 anchors, particularly at 11 and 1.
Yes.
So do you face any difficulty? I think you did the thought like this way so that you can use the biceps. But if you do keep the bicep, is exactly at 12.
Yeah, because I didn't do actually, I didn't plan for the biceps augmentation along with the SCR. The problem, what I finally realized that what the measurement which I took was not covering the entire footprint of the lateral side. Then I thought, because the biceps quality is not very bad. When you saw that, video, the biceps was still very good. So I thought, why don't we cover that remaining space with the biceps augmentation? So I did as a last procedure to do tenotomize it in the biceps groove and bring it and attach to the tuberosity. So that was just last option. I didn't plan it.
Yeah, because this is absolutely a new idea because the way we have been seeing people doing the SCR, and also we have been doing we first take off the biceps just to clear the supraglenoid area so that we can put the anchors properly over there at 11 and 1 so that it becomes absolutely at the center.
Yeah, basically it's a very new procedure. I think the indications are very, very few. So as I said, I don't do many SCRs, but because that case I had done, I showed you. But many cases, as I said, no, because considering the cost of the surgery and outcome of the surgery, still we are not sure how many of them are doing that. Getting the functional outcome because of the SCR alone, because we don't know, because this patient we had done a infraspinatus partial repair also. So outcome is I am not sure because I don't have the experience to say now. Maybe the very few papers on the superior capsule, but anyway, there are many papers are coming with not very good results. It's not like what nobody can reproduce the Mihata results. So I think the indications you have to be very careful in doing these procedures.
Yes, another one complication of SCR is your probably many percentage of infection. People are coming with that with the SCRs. And also even the SCRs are failing, the graft failure. You don't know how much is the healing potential. So all these are still fingers are crossed. Even the papers are coming with the Mihata after the Mihata this thing because yes, Neha, is there any question? I think you are saying something.
So how do you measure exactly how much graft you need, the lengthwise and widthwise?
The lengthwise, I think we should try to get at least 6 to 8 mm thickness of the graft. So you should get at least around 22 centimeter. The incision you can take a full open procedure like which I did, like full open, but people does nowadays with just 2 incision on either side. You may require around at least 22 centimeter length of in the thigh. You should make an incision over there if you want to make a full open procedure. So, and you can fold it 3 times or 4 times depending upon the length. And also the measurement what you take. So according to that, you plan it. But at the end, you make sure that the thickness is the very important. So they say that many failures, mainly because of the thickness, if it is 4 mm or less, they tend to do failure, even if the facial graft. That's why the dermal allograft also.
Yes, completely agree. Yes,
they
completely
come with only 4 mm. So they tend to elongate also. So I think even for the facial lata, we require at least 6 to 8 mm graft.
Neha, to measure the width and the length, mediolateral and anteroposterior, you can use a simple ruler or various instruments are also available with various companies. So if you want to measure it on the glenoid anteroposterior, go from the anterior portal and measure it. Similarly, on the GT side, you can. And through your lateral portal, you can measure the mediolateral width. And whatever width is there, see that you take 1 centimeter extra on all the 4 sides. But I think it's very technically demanding surgery also, and we really don't know how much tension to put when you are repairing the lateral side, and how it's not elastic like the rotator cuff.
Yeah, I agree.
What we reduce and what we have usual feeling of pulling the cuff and getting it down. So what we apply that thing only, but it's very difficult to pull that capsule and put it on the lateral cuff. So we really don't know how taut it sits on the proximal superior aspect.
Yeah, that's why the measurement is very critical.
Yeah, very critical.
Measurement of the graft which you require is very critical. So make sure that you go at least 1.5 centimeter in the glenoid level. And also the lateral side, you should go up to the lateral end of the tuberosity and measure it. Whatever it is there, you take 1 centimeter everywhere for the anterior, posterior, and medial and lateral. Because when you make even the preparation of the graft, when you stitch it back, it folds for at least 0.5 centimeter. So that's why the length and breadth of the graft is very crucial.
Yes, yes.
Thank you, Dr. Sundar.
Satish is there? No?
Thank you. Thank you.
Yeah.
Satish
Is Satish available?
No, Satish is not there. Still he is not there, Mukesh.
So I think
we can go ahead with the fifth one.
Right. We can now I invite Dr. Mukesh Ladda for his talk, simplifying the tough and strong subscapularis.
So good afternoon to all. So let me start, and everyone have mentioned the importance of subscap, and we also know it's one of the most important and strongest rotator cuff among all the four tendons. So anatomy, we know it comes from the anterior surface of the scapula and attaches on the lesser tuberosity. It is not only the main internal rotator of the shoulder, but it also provides anterior superior stability to the shoulder. If it is not there, there are shoulder humor, proximal humeral that tries to shift anterior superiorly. And also it is important in maintaining the force-couple mechanism, the way which we are thinking about why few patients have good movements in spite of a very bad posterior superior cuff tear is because of intact subscap, and it provides 50% of the total strength to our rotator cuff. I'll just go to the relevant surgical anatomy, a nice article by Professor Yu about the four facet anatomy, and important is that the first two facets are usually provide 60% of the entire footprint, and the lower two are usually the muscular attachment. So all these four facets are important, and we should understand this anatomy. This is what usually we say the subscapularis has a comma shape insertion. Its proximal is a broad insertion of facet 1 and 2, and distally it's a comma shape. So it's a comma shape insertion. So this pull of the muscle is important because while you are placing the sutures, the direction of your sutures should be such that it pulls the subscap back to that from medial to lateral and from inferior to superior. So it's totally different footprint, totally different muscle pull and tendon pull compared to the posterior superior cuff. So here the proximal end of the subscaps comes from medial to lateral, and the inferior or middle and inferior comes from superior to inferior to superior. Though less known, but if you see the literature, it has a 50% tear incidence, whether it's type 1, 2, or 3, and it's seen more frequently in patients above 50 years of age. Especially be careful in patients who have primary traumatic dislocation above the age of 40. I think we should get an MRI done in all that patients who have primary acute traumatic dislocation above the age of 40 or 45, and so that you won't miss this kind of subscapularis injury in such patients. We all have discussed this in our last webinar as well as today, importance of force couple and how subscapularis plays an extremely important role in transverse force couple mechanism. So etiology of subscap tear, usually it is traumatic, as I told you, in dislocation above 40 years. Isolated do exist in around 5% of patients. So when it's a traumatic tear, it's usually type 2, 3, and type 4. Usually then, if it's a degenerative tear, it's usually anterior superior and secondary to coracoid impingement as well. And they are not that massive compared to traumatic tears. This facet classification by Professor Yu has divided it into 5 types. Type 1 is just fraying. Type 2 has divided into A and B, where less than 50% of subscap tendon is detached and more than 50% with a complete disruption of the lateral band. Is type 3, where the entire first facet is visible, and type 4, where the first two facet is completely torn, and type 5, where complete subscap, including the muscular portion, is torn. Lafosse classification takes into consideration not only the tendinous part but also the migration of the humeral head and subluxation. So in type 4 and 5, where it is a complete subscap tear, but head is centered in type 4 and the head is anterior superiorly subluxed along with fatty infiltration. So it's very difficult to reconstruct the subscap in type 5, but you can do it definitely in type 2, 3, and 4. You should know the both classification. They are very helpful classification when you are planning your repair and then. So clinical examination, usually we all know, and last time it was covered very well, belly press, lift off and Hawkins bear hug test are the sign which we can identify whether it's a type 1 or type 2 or complete thickness involving both the facet. Impingement test, we should always see and look for coracoid impingement the way we look for subacromial impingement. It is forward elevation, adduction and internal rotation. If patient complains of pain on that, you should suspect coracoid impingement and correlate it with your other findings of subscapularis like bear hug or your belly press test. Imaging wise, we do all standard imaging through anteroposterior to see how much amount of coracoid is coming over the humeral head, which is an indirect sign showing that the patient may have coracoid impingement. Proximal migration and the outlet view, if there is anterosuperior migration and the acromiohumeral distance is less than 5 to 6 millimeter, then you have to really worry whether you can able to repair the subscap or other cuff which is involved with subscap. MRI is no doubt is the gold standard in diagnosing the subscap tears as well as to quantifying the tear. We see subscap very well on the axial cuts. As you see here, the anterior subscap is completely intact, and on the sagittal image also you can see the footprint with the intact rotator cuff. And as you go down, you need to quantify muscle atrophy and fatty infiltration to decide whether it's a repairable or irreparable subscapularis tear. As in this MRI, you can see that this full thickness type 3 subscapularis tear and the biceps tendon has dislocated and came anterior to the lesser tuberosity. And the lower picture, you see the biceps tendon is still in the groove, but you have a full thickness type 2 and retracted subscap tear, but it's well lateral to the glenoid. So you know you are able to repair as why we show amount of fatty infiltration. I do all my rotator cuff repair, even subscapularis repair in the lateral position. That's the position which you give. Most important is the surface marking. In any shoulder procedures, I'll ask everyone whether it's a newcomer or a well settled. I think every one of us do surface marking. That's the lateral border of the acromion. That's the palpating the clavicle, and then anterolateral end of the acromion. Coracoid is important landmark, so mark it properly. Your acromioclavicular joint and a line from posterior acromion to divide the shoulder in anterior and posterior third, so you know how to make your portals and you know the anatomy very well. Usual portal is posterior, India portal is usual portal, posterior lateral. Subscap, I do all intra-articular subscap repair. If you wish, you can go into the subacromial space and work from there also through a anterolateral portal. But for subscapularis, I have these two portals, anterosuperior and anteroinferior portals, which we use for our labral work. And if you want to go through the subacromial space, see that the anterolateral portal is little anterior than the conventional portal what we do for supraspinatus repair. So once you enter now, see how beautifully and intricately the superior glenohumeral ligament is attached to the upper half of the subscap. That's the superior glenohumeral ligament going and getting attached anterior to the biceps tendon and with the subscap tendon as well. That's the middle glenohumeral ligament coming and wrapping the proximal end of the biceps tendon, going around and getting attached anteriorly to the biceps tendon as well as with the subscap. That's the middle glenohumeral ligament, and that's the anteroinferior. This correlation of ligaments with the subscap tendon is important because you need to know when to release which. So I'll take you through stepwise repair of subscapularis, verifying the subscap, exposing the subscap, releasing the adhesions to have an anatomic tension-free reduction, footprint preparation, anchor placement, suture passage, and final check. This is often called as a hidden lesion or concealed lesion, and this sentinel sign popularized by Lafosse, there sometimes you don't have a clear picture of subscap tear on MRI as well as clinically. But to know whether it is really torn, you need to see the lesion on the biceps tendon posterior-medially, which indicates that there is some injury to the biceps pulley and the superior glenohumeral ligament. So that is sentinel sign, the lesion on the posterior-medial aspect of the biceps tendon, giving you the clue that there is a subtle injury to the subscapularis tendon. As in this video, there was just the intrasubstance tear, but it was completely intact from the footprint. So know well and try to find out the subscap, because most of the times it's a hidden lesion. So verifying this is, see, you can sometimes be very lucky enough to see that full type 1 subscap tear along with the associated supra and infraspinatus cuff tear. But to facilitate your viewing of subscapularis, ask your assistant to give posterior force to the proximal humeral head and internal rotate. Then you will able to see the subscap in toto. As in this, you can see another patient with intact biceps tendon, but you can see the intact superior glenohumeral ligament and the full thickness supraspinatus tear from facet 1, or you can say type 2 from the Lafosse classification, as well as the supraspinatus tear. So isolated subscap tears are rare. Usually they are associated with anterior superior cuff tear. If they are traumatic one, then infraspinatus may be involved with them. So this is another one where you need to verify and identify the subscap first. As you enter subscap, you see there's no biceps tendon at all, because that has also been torn and adhered to the on the lateral surface of the cuff. This one, again, there is a full thickness biceps tendon tear in the bicipital groove. There is a complete emptiness in the bicipital groove, and the tendon has been torn at the bicipital groove level. I was unable to see the subscap. This is a rare case where it was an isolated subscap tear secondary to traumatic dislocation in a 50-year-old individual. And you can see the whole footprint of the subscap was visible. There was a bare area on the lesser tuberosity, but the subscap was nowhere. And when you go little medial, you see that's the superior surface of subscap, and it was lying medial to the neck of the glenoid. So verifying and identifying subscap at the initial go is very important, because otherwise you'll start releasing it at wrong places. So clinically, if you suspect, radiologically look it for it. Even if you don't suspect, always make it a point to pick up that subtle upper 1/3 tears with sentinel sign. The next step is to expose the subscap. So the most important thing in exposing the subscap is to do a good rotator interval release, either with shaver or RF. See that if you are using your shaver, the mouth of the shaver is towards the biceps tendon and not towards the subscap, so that upper proximal margin of the subscap is very well visible and you don't damage it. Again, the importance of comma sign. As you see, it's the tissue connecting the upper part of the subscap to the anterior part of supraspinatus. Clearly visible. That's the upper border of the subscapularis, which is such a fibrous because of trauma. And that's the biceps tendon, which has been torn and attached itself to the comma tissue and the remnant of the anterior superior cuff. The important step after you have verified and identified the subscap tear is the release. So you need to have 3-sided release for the subscap. So the first one starts in the rotator interval. You may call it as proximal release or release superior to the subscap tendon. See that your tip of the probe is away from the tendon, and you release complete rotator interval along with the superior glenohumeral ligament, coracohumeral ligament, till the time you see the coracoid from inside. Again, viewing from the posterior portal, coming from the anterolateral portal, that's the tip of the coracoid and the fibrous and thickened rotator interval. Slowly, gradually release it with coag and see the bleeders you catch hold of there. And with every release, with the help of your probe, try to pull the subscap to its footprint so that you can go medially and start releasing it. Be careful in subscap anything medial to the coracoid is dangerous. So see that you are lateral to coracoid and release everything which is under vision. Don't do any blind releases. And the tip of the probe away from the tendon of subscap. Then comes the posterior release to the subscap, but you are anterior to the humeral neck. Here, glenoid neck. Here you need to release the capsule, which is there, or sometimes it's a very, very thickened middle glenohumeral ligament. So you need to know how it is attached, and sometimes to facilitate proper reducibility of the subscap muscle, you need to go and release middle glenohumeral ligament along with the thickened capsule, the synovial tissue. So this is the patient where it was stiffness because of the long-standing problem of subscap tear. And then I slowly went in and did anterior capsular release along with middle glenohumeral ligament release. See that you release it only up to the inferior glenoid. Don't go much inferior because of associated subscapularis nerves there. So need to do a good superior release first and then a posterior release. And lastly comes the anterior release, where you can easily from the posterior portal, when you have done the 2 release, put your scope anteriorly, your RF coming from anterolateral portal, and you are working between the coracoid and the anterior surface of the subscapularis. Release all the adhesions anteriorly, and that is also under vision. Be careful, sometimes you can form accessory anterior superior anterior inferior portal. Again from posterior portal, come anteriorly, slowly and gradually keep releasing medially. And after every release, take a pause of a fraction of second and so to see you are not close to the neurovascular structures. That's the conjoint tendon, which from the tip goes inferiorly. Be careful because musculocutaneous nerve will be there or your axillary nerve will be there if you go quite medially and inferiorly. And as I told you, gently after every release, see that you are not damaging any nerve tissue. If you feel doubt, just don't use your cautery, just elevate it with the probe and see that you don't damage the tissues. So you need to have an excellent anterior, posterior as well as superior release. That's the view from the anterior superior portal. I'm using my switching stick from the posterior portal to lift the subscap, and I'm seeing completely under vision and releasing anterior to the subscap. There are a lot of adhesions anterior to the subscap. So be careful and be enough, sufficient release is needed, but also very generous release so that you don't damage the vascular neurological structures there. After you release, you must have this easy reducibility of the subscapularis. So if you still feel that the subscap is not getting reduced very well, see and go again anteriorly or posteriorly to release your subscap. But for a good repair, the reducibility of the subscap is very important, like any other cuff. You should be able to get it very smoothly to its footprint. Once you do that, then comes the footprint preparation. Remove the fibrous tissue with the RF and then use your burr or your ring curate to just decorticate the lesser tuberosity. As you see here, I am removing, and the whole lesser tuberosity is very well visible with your posterior portal. You can use 70-degree probe scope if you have that luxury, but if you are having a 30-degree scope, still you can able to see the whole footprint from intra-articular. No need to go through the subacromial space. As you can see here, I'm completely able to visualize the footprint. That's the supraspinatus GT footprint. Just rotate it externally and you will see the bicipital groove and the whole of the lesser tuberosity clearly visible for your anchors to be placed. If it's only upper 1/3 tier or type 2 tier, you can easily manage with a single anchor after footprint preparation, whatever anchor you prefer. It's an open architecture anchor or a closed bio anchors. Or if it's a full thickness isolated subscap tier, I use 2 anchors. One anchor go inferiorly, as you see here, and the second anchor comes at the cartilage junction, exactly where the subscap footprint is there. Usually 2 anchors are sufficient enough. You have full thickness subscap tier, but single anchor for an upper third or upper two-third of tier. I usually take, as mentioned by Vikram also, first 2 bites go from inferior and superior, and the next 2 bite goes medial and lateral, because I want to pull my subscap from inferior to superior as well as from medial to lateral. So it's a type of modified Masson-Allen stitch. As you see, the first bite is inferior and the second bite is proximal to it. So it's a superior-inferior type of bite. And the third bite I take at medial to this first 2 bites and in the center of it. As you see, because I'll tie that first and then I'll take over this mediolateral bite. As you see here, I am medial and inferior to my first 2 bites, and the third bite, again you see it's going medial to the first 2 bite, and the third bite or the fourth bite will be lateral to the first 2 bite. So it will form a cross connection like this, superior inferior and mediolateral. So it won't cut through, and that's the final repair after you have done good reduction, good releases, and rotate it medial internal rotation to see there is no lift off, and external rotation to see it glides very well. And that's the knot taken on the anterior surface of the glenoid. That's the view from the anterior portal. See the whole subscap coming from medial to lateral, and the knots tied in a crisscross fashion anterior to the subscap. And after you finish, see and check with the rotations of the shoulder. It should not be too tight in the internal rotation. And if you feel it's very tight, you need to see that there is some tissue still tight, you release it. And that's the importance of comma tissue. If you retain it, the subscap supraspinatus automatically gets good reduction. So this is the patient, again, as I'm telling you, with dislocation, drop arm positive, full subscap, supra and infra with dislocation of biceps. After a good repair, you can regain normal function of the shoulder with full function and no drop arm in a young patient. Another patient, all mentioned, also he had a severe drop arm, unable to lift because of the traumatic subscap and supraspinatus cuff tear. But once you do a good subscap and your rest of the cuff repair, they regain full movement with normal strength and other things. Various literature also mentions that above 40 years, be careful. The types of repair, single row or double row, depends on your expertise and your economic status of the patient. But here in India, I think the patients have a small shoulder compared to European shoulder. I think single row repair with all intra-articular repair also gives excellent results. So I would like to end by saying you know your subscapularis very well, because they're the strongest cuff and have a 50% strength of all the cuff available. A good clinical radiological evaluation to know that you are dealing with subscap tear. Know its footprint very well with the recent literature by you in the foot facet anatomy. Know the tear patterns type 1, type 2, type 3, because they are usually seen in more than 50% of patients. And if you don't deal with these lesions, there may be a constant source of pain anterior on the shoulder. It's a concealed lesions. Look at that sentinel sign. Repair it whenever possible, as it's the very strongest cuff. Thank you.
Thank you, Dr. Mukesh. Excellent talk and nice videos. Any question, dear Jagtap?
Mukesh, unmute the, yeah. Yeah, very nice talk. Satish is finally has appeared.
There is an issue with the internet.
Okay.
I think Dr. Vishal, from your side, you can.
Dr. Vishal, any comments?
Have any questions?
No, I think
Vishal?
Mukesh has covered it brilliantly. It is a difficult repair to achieve because of the numbers. You do supraspinatus, infraspinatus all the time. Subscap is quite rare, and it is quite the access is a problem. So yeah, he has covered everything brilliantly. To be honest, I don't have anything to add. The only thing I wanted to say about the previous speaker, Sundar, he presented about the SCR and the balloon spacer, because I was one of the first ones in UK to do the balloon spacer, and I did 3 cases. and I had very bad experience. So I would say best is to avoid that spacer completely. So about 10 years ago, I did these spacers that companies from Israel, and I had very bad results. All three of them failed actually. So I stopped doing them.
No,
And
I think even the companies are not telling that not people, most of the part in the world, they are not taking this seriously.
yes, but that company is very aggressive. So
Yeah,
it
yeah,
kind of
yeah.
does a lot of marketing and pushes you. But yeah, so one of my patients had the rupture of the balloon, and she came with bruising and a lot of problems. The other two balloons slipped from position. So it is absolutely useless, actually, in my opinion.
I think they're coming again and again. I know all the literature has shown a lot of failures. I think the people are coming back again because of the market, and I think more of company push.
Okay.
Yes, I think with the permission of Jagtap and everybody, that the most one point that I like, the most important point from the Lada's talk is that whenever you see a dislocated freight biceps, please look for the subscap, because that
Okay.
is
Yeah.
because that is the most important message. Probably he has stressed upon thrice there in the talk. This is the most important message for the juniors.
Yeah.
Because subscribe, even with your scope, you can miss it.
Yeah.
Totally agree.
Yeah.
You need
So-
to probe and look it.
Okay. So before Dr. Sonar loses his network connection again, we would like him to present his utilizing biceps in massive curve.
Can you see my, sorry for the inconvenience because of internet issues. So can you see my slides?
Yes, we can see it.
Yeah. So I love the biceps, and this love story begins in Milan when I was with Alex Castagna in 2006 and 7. And he used to use the biceps in a cuff repair, but he has not presented it anywhere, but he used to do it very frequently. And from that time, I also started using the biceps in the lot of cuff repairs. I don't like to cut it and throw it away, because it's a very useful and live collagen tissue which you can get easily available in the shoulder. So in all the chronic cuff tears, and when there is a tear with a subscap tear, the biceps is either dislocated or subluxated into the joint, and it's a pain generator. And so we have to do something with the biceps. So that biceps is very easily available, which can be used and incorporated into your cuff repair. And it's a very useful tissue which you can easily reroute into the subacromial space, and then you can use it accordingly as you like. And it's avoid the expenses and of the patch, or even avoid the additional procedure like taking a graft from the IT band, or like a tensor fascia lata. And it's a very vascularized collagen tissue, and has also increases the healing potential of the traumatic cuff. So what are my indications for using the biceps? It's usually a mainly old retracted cuff tears, usually the anterior part of the cuff supraspinator, which I cannot bring it to the tuberosity. That time I use a biceps to elongate it, or act as a bridge graft whenever there is an unreducible supraspinatus. In the bursal tear, there is a lot of fraying of the bursal tissue, and there's a loss of some amount of the cuff tissue. That time ideally you require a patch graft, but the patch graft is not easily available in India. So you can use this biceps tissue as a patch graft. So the contraindications, as you can obviously consider, at pasta lesion, and whenever there is a diseased or very torn biceps tissue. And this technique of using the biceps has been first published by Professor Young Ri in 2008 in American Journal of Sports Medicine, and it's a very useful article. So I always do my shoulder surgeries in lateral decubitus position. For the cuff, I use 4 portal: posterior, posterolateral, anterolateral, and anterosuperior. So I first do biceps tenotomy and read it into the subacromial space. Then in the subacromial space, in 8 out of the 10 patients, I do acromioplasty and AC resection. Then as per the tear pattern, I mobilized the curve. It is too far retracted and not coming very easily to the tuberosity, and then do a gentle GT roughening or preparation. So in the bursal tear, there is a big, you will always see a big acromial spur which damages the bursal part of the rotator cuff, like you can see in the third slide. So this is a patient. You can see a clear crisp subscap, excellent from the intraarticular view. So then I gone into subacromial space, saw the tear, and then come back into the intraarticular space, mobilize the biceps all around, did a acromioplasty, lateral end clavicular resection that will decompress the whole AC joint. And this is the tear. Put a medial anchor, take a bite through the cuff, then take a bite through the rerouted biceps and buried that biceps into the torn bursal sided tear, and then pass those sutures, laterally into the lateral row. So this is another patient who had a subscap tear. Subscap has been repaired. There is a big acromial spur. You can see this, the acromioplasty is done. There is a flat acromion after the acromioplasty. This is a big hole in the cuff. I did a crimson duet, then pass a medial anchor. Take a one bite of the anchor through the cuff and another bite through the biceps, so that I will be able to use that biceps and pull it into the lost tissue of the subacromial, the bursal surface of the supraspinatus. This is a bite through the biceps. So when we will try these two sutures, this biceps will be pulled into the defect, and then you can pass a lateral row anchor and you will get a smooth subacromial portion of the supraspinatus. That was the intraarticular portion. So when there is a big retracted cuff tear, but it can be easily brought to the tissue, but you will find that there is a lot of bursal fraying of the tissue, or you find that the supraspinatus is very thin. That time you can use a biceps as a patch graft. So this is a patient who had a complete calcification of his both supraspinatus and infraspinatus. I mobilized the biceps, reroute into the subacromial space, did a acromioplasty. This is a arthritic AC joint. So did the AC resection so that I can get about 8 to 9 millimeter of the space in the AC joint. So now you can see this complete rotator cuff was calcified, and he had a severe night pain. He was not able, he has slept since last 6 months and has done everything, but he was not able to get relieved of his pain. You can see his old supraspinatus and infraspinatus was calcified. These are the big chunks of calcified tissues in from his rotator cuff. You can see this is a big, thick and calcified mass in his supra and infraspinatus. It took me almost 1.5 hours to remove all these calcified mass. So after that, you can see this is the cuff, and it is very thinned out because of lot of calcification into it. I have to medialize that cuff. I pass anterior anchor. I always use triple loaded anchors in the medial row. Then I pass the sutures through the cuff one by one. So all these steps are repeated again and again. Then the second anchor is passed posteriorly. Same steps are repeated. So finally, you can bring the cuff up to the medialized tuberous footprint. But since this cuff is very thinned out because of lot of calcified mass into that supra and infraspinatus, I thought it can re-tear. So you need some another procedure. So I brought this biceps tendon into the subacromial space and patch it on the repaired supra and infraspinatus, just like a patch graft. So this will provide a live collagen tissue, and it will also reinsure that the cuff will not re-tear in the future. So it's just like a patch. So in some cases, the cuff is too much retracted. Even after the thorough release, you will not able to bring the anterior part of the cuff to the tuberosity. That time you need some tissue. Either you can do a SCR, or you can use a dermal patch to build up that tissue. But I always use a biceps to reinforce those tissues. This is a lady with a big tear from anterior to posterior, from subscap, supra, infra, and even the part of the teres minor. I did a subscap repair. This is a nice subscap repair. So this you can find that the cuff is too much retracted. I have to release it under the coracoid. I have to release the coracohumeral ligament. Then I have to release this posteriorly. Still, it was not coming up to the tuberosity. Then so this is the release anteriorly. Then I have to release it from the capsule on the under surface gently, not damaging the cuff. And you cannot go more than 2.5 centimeter medially, because there can be damage to the suprascapular nerve. So after the release, you can see it can be brought back to the tuberosity. But again, this cuff tissue was there since 2.5 years. So you need to provide some more collagen to it so that it will not re-tear because of the tension. So I put a biceps, incorporate the biceps into that tissue, and then pass these lateral sutures under the bicep, so that the biceps will be buried into the tissue of the supra and infraspinatus. You can see the biceps has been completely buried into this repaired supra and infraspinatus. And this patient has a very excellent result. You can see this intraarticularly. The cuff was tightly sitting onto the medial footprint. So this patient, you can see there is a loss of the anterior cuff tissue. The supraspinatus is completely damaged, and you will not able to reduce it or bring it back to the tuberosity. And that time you either need a dermal patch or some form of the SCR to bridge that tissue. And in such condition, I use the biceps to bridge the gap of the lost supraspinatus. You can see that you cannot able to mobilize it or bring it up to the tuberosity. And in such conditions, you can use biceps to cover that gap. So this is another patient. You can see this is a torn supraspinatus. It is hardly mobile. It gone stuck to the medial portion of the tissue. The infraspinatus can be easily brought back to the tuberosity. The biceps is also mobile. You can bring it up to the footprint. So I pass the anterior anchor, pass it to the biceps, and pass the same suture through the supraspinatus, which I could not able to bring it to the tuberosity. So now these biceps will act as a lost supraspinatus, and then you can do a repair and you will get a nice footprint coverage. So this article has been published by Youngel Ree in American Journal of Sports Medicine in 2008. So you can use the biceps as a bridging graft in a lost tissue of the anterior cuff. So the another technique recently published by Chiang and Shaw in Journal of in Arthroscopy Technique Journal, where that biceps has been rerouted in a L-shaped fashion, which I also doing since a few years, and then bridge it, use it as a bridge graft for the lost supraspinatus, and then repair the infraspinatus around it, and you will get a nice repair. And this biceps will not only act as a SCR, it will provide a live collagen to the lost anterior cuff, and you will get excellent results. So in such condition, I always use an arm pouch for 6 weeks, I think for 7-8 days. Then I start the passive ROM from 3rd week. I avoid pendulum exercises for 6 weeks, though it considered as a passive exercise. Pendulum is almost always an active or active assisted exercise, and it will put a lot of stress on the repair curve. So always better to delay the pendulum exercise for 3 to 4 weeks, but you can start the scapular exercise early from the 2nd week. Then you will get a full passive ROM by 6 to 8 weeks. Once you get a full passive ROM, then you start active assisted exercises, yellow TheraBand to green TheraBand exercises for subscap and infraspinatus, followed by supraspinatus, and then you start delta and deltopectoral exercises, and then gradually progress it further. But always delay the pendulum exercises for 3 to 4 weeks. So post-operatively, you get an excellent result. This man has a cuff tear since almost 2 years. He has completely lost his supraspinatus. I have to use the biceps to build his anterior cuff, and he's been operated for the left shoulder. He has almost normal function as his right shoulder. Good belly press, excellent strength for the bear hug test. Lift off is also good. He has also has a subscap tear, which I repaired it. This lady was operated for right shoulder. This was the video I shown. She has a torn tear for almost 2.5 years, which I have to incorporate biceps into her tissue to provide her the extra collagen so that I can avoid a re-tear. So in conclusion, the massive retracted tears, the too much tension on the repair can
Hello.
I think Satish has we have lost contact with Satish. Is it?
Satish.
Hello.
Yeah, we got thank you from Satish.
Hello, Satish.
We have lost him, I think.
I think his net is not working.
Yeah.
I think he finished his talk, so we can go.
More or less, it was over. More or less, last slide. Yeah.
I think he has rerouted his internet for the time being.
The witty one-liner by a president.
So thing is that now many people are thinking that biceps should not be sacrificed. It should be adjunct to this calf repair, massive ones. So I think a lot many techniques are coming and people are doing it. Jagtap, your opinion on that? Sundar also can give expert
Very
opinion
nice, very nice technique, and it is a biological graft augmented. It is there in place. It is cheap, maybe technically little bit demanding, but that it must be used whenever it is possible and required.
I think whenever there is an intra-articular portion of the biceps is intact, I mean, unless if we think there's a problem in the groove or distal to that, the intra-articular portions are can be nicely used.
Satish has joined.
Yes, yes.
Nice topic.
Nice.
Very nice. Results
you,
are really good.
Yes, and also the schematic diagram and the pictures were really explaining everything about the topic.
Thank you very much.
Nice one.
See, even Jagtap, even now see, some people are even comparing the results of some repairs along with your biceps, this rerouting. They are not taking the SCR seriously. Rather, they are taking this one seriously.
Yeah.
Agreed.
Exactly.
So I think if there is no question, we can move ahead to the cases. Jagtap?
Yeah, sure.
Because last time.
Neha, please go ahead with your case.
Not there, so I apologize for that because that time the time was really overshooting. So now today we'll be taking the cases. Okay.
Yeah.
Neha?
Yes, sir.
Please go ahead with your case.
Yeah. Am I visible?
Yeah.
So, good afternoon, everybody. This case was regarding my our last session, which was basic rotator cuff. So, I'm Dr. Neha Godgate, orthopedic surgeon from Nagpur. First, I would like to extend my gratitude towards our parent society, Arthroscopy Society of Nagpur, and Indian Arthroscopy Society, and also Arthroscopy Society of Nepal. Today, I'll be presenting a case on rotator cuff tear repair. So, a 42 years old lady presents with a chronic shoulder pain since 2 years, which has aggravated since 2 months, followed by a minor jerk, so much that her sleep as well as her daily activities are disturbed due to pain. She had been taking treatment with a neurophysician for the left arm pain since 2 years. On a clinical examination, her cervical spine examination was within normal limits. However, she had a painful terminal range of motion of left shoulder with weak and painful supraspinatus muscle, and test for impingement was positive.
विवान ये क्या पैजामा छोटा है तुझा?
मुकेश आपका ऑडियो म्यूट करो.
Sorry for the interruption.
Yes, Neha, you can go ahead. Mukesh has already been muted.
The base of any investigation being an X-ray, the AP shoulder view was taken, which revealed that subacromial sclerosis with a lateral spur and greater tuberosity. There was an irregularity over greater tuberosity. The critical shoulder angle was 41 degrees. The critical shoulder angle is the angle subtended by the line drawn from superior glenoid tubercle to inferior glenoid tubercle, and another line from inferior glenoid tubercle to the lateralmost part of the acromion. And the angle more than 35 degrees is thought to be associated with cuff tear. Moore et al. In his case control study proved that the critical shoulder angle is the strongest predictor of cuff tear. The patient presented with mainly cervical spine sequences which look nascent. There were few MRI shoulder cuts. The coronal T2 weighted image showed that there was a hyperintensity in supraspinatus and fluid signals in subacromial space, and acromial spur was also visible. The acromial, the T1 sagittal view showed comparatively a fairly healthy supraspinatus muscle. The subscapularis muscle appears pristine on transverse sequences. So, considering the pain and restriction of daily activities and non-responsiveness to the conservative trial, it was decided to do subacromial decompression. The patient was in lateral position with osseous landmarks were palpated and marked. The first diagnostic round of glenohumeral arthroscopy was performed. The biceps tendon showed mild inflammation in the bicipital groove, and there was a fraying of fibers of supraspinatus seen on the articular surface. In subacromial arthroscopy, the scope must pass anterior to the midpoint of the acromion to pierce the veil of the bursa, and there is a fraying and degeneration of coracoacromial ligament, consistent finding with impingement. Half of the rotator cuff surgery consists of thorough bursectomy with the help of shaver and the tissue ablator. We begin subacromial decompression by recessing the coracoacromial ligament. However, in cases of massive rotator cuff tears, this division is avoided as it can destabilize the shoulder anterosuperiorly, as already been shown by our previous speakers. Gradually, a bursectomy is done after assessing the acromion for any overhang or spurs. The acromioplasty is performed with the help of burr, and plane of resection is defined first laterally and then gradually moving medially. So, like a windshield wiper. So, this is a before and after picture of the acromioplasty. So, subacromial bursal shaving is done thoroughly, and medial shaving would lead to bleeding like this. The field can get occluded by the bloody lesion. However, it is mandatory to have some patience and use a tissue ablator to find the bleeding point, and slowly the field gets clearer at this point. At this point of time, the manual pump inbuilt in the fluid irrigation set is a good use. Dr. Yeeps in 2007 mapped the bleeders in the subacromial space. This is a very good article, and knowledge of these bleeders would help to prevent the shaving near major bleeding vessels. On palpation, the bursal site tear looks like element B2 category. Hence, it is amenable to repair. It has been well established that there has been a time-dependent risk factor for the tear enlargement in such cuff tears. So it was decided to repair, and with the help of shaver, the osteochondral irregularity, which is seen over this with the palpation, that irregularity was shaved off. So once the bed is prepared properly with the help of shaver, the double-loaded suture anchor was inserted, and with the help of anti-grade suture passing devices, both the threads were passed through the musculotendinous junction through the supraspinatus tear. It is mandatory to take a good care while passing these sutures, because there is a risk of entanglement. So then comes a knot tying. The final repair is done with the help of with sliding knots, and at the end of repair, there is enough subacromial space for the tendon to move freely. So this is our 1 year follow-up. The patient has got good range of motion. She is painless and happy. So prognosis in my case depends on the following factors. These are the parameters. The age less than 50 has got good healing chances. Yu et al. In 2017 proved that tears less than 2 centimeter squares have lesser re-tear rates. However, they had more post-operative pain owing to robust healing. And there is no difference between healing of trauma and non-trauma group. And any good muscle bulk has a positive effect on healing. So discussion of tear progression. Keener et al. And Su et al. They actually calculated the risk of tear enlargement, and they told that at the end of 2 years there is a risk of 11% risk of tear enlargement, and at the end of 5 years 50% up to the as high as 50% tears can enlarge. Namdari et al. In their paper showed that the disruption of anterior supraspinatus tear in painful small tear was later associated with greater tear size and muscle degeneration. Moll et al. Concluded that there is a positive correlation between pain development and enlargement of the tear. This was a large database study from USA. It included almost 8.78 lakhs of patients, and they conducted the study from the duration of 2005 to 2012, where they concluded that the rate of surgery has gone up from 33% to 40%. However, the patients who had given a trial of injections later required repair. So learning points in my case was clinical examination is of utmost importance, even in the era of escalating Tesla. In the case like this, where MRI did not show a frank tear, the patient counseling was important. And in all the cases, the surgeon has to be ready with all his or her armamentarium, as you never know what surprises you will come across. Thank you.
Hello.
Yes, yes.
Yeah, I think very, very nice case presentation, very comprehensive, very good literature, very nice. One of the best case presentation I have seen.
Excellent
Very
case,
nice.
Neha.
Excellent, excellent.
Want to ask Sundar as well as other guys, in such patients who there is a very small size cuff tear, but really they are very long standing. So what is your cutoff line? 3 months, 6 months of rehab and other things, and then you advise for surgery? And how confident are we to know that that is exact cause of pain? The same what Neha's case was. Yeah, Sundar, please.
I think that many times the patient comes to me probably after 3 months or 6 months only, because the patient might have been treated in the local places, especially when come to like our places like a refer hospital, they come after 3 to 4 months of tried with the conservative management. I think one of the clinical examination, what Neha mentioned, everything is absolutely perfect. In my opinion, I think especially male patients, if they're more than 40, if they're less than 60, I would examine the acromioclavicular joint, because many patients, they say mimic impingement. It is very, very important, imperative. Even the patient may have an impingement. This case may be a perfect impingement case, but I'm saying that in some other cases, they can have an impingement syndrome. Clinically may look like they can have a partial tear in an MRI scan. But if we see clinically, if you examine the patient, that patient may have a exact tenderness over the AC joint. Hawkins stains could be a positive. Then many times that can be missed and people can go and do that impingement surgery. So for the youngsters, it's very important the clinical examination, not the MRI report. Correlate your clinical findings, examining not just impingement and other cuff test, along with AC joint should not be forgotten. That is the most important step, I agree. And second line of treatment, my treatment also, these kind of patients, I try corticosteroid injections. Many patients, not only for the AC joint, because the AC joint pathology, many of them will become all right if we give an injection. The same thing for the impingement. For the impingement, also in the age group of this age, sometimes I can give one injection. So many patients may become all right. If they fail, again, as I will do the same procedure like how Naga did. I think that is the approach for my patients.
One question. So after the injection, how long do you wait for surgery?
Yeah, that depends upon the patient. No, the patient, no, usually I just see them after 6 weeks time. All the patients usually I see in 6 weeks interval. Many of them, if they become all right in 50%, 60%, then I tell them to continue physio, come back after 3 months time. Then if they say that again, no, I'm not completely relieved, I need a complete relief, then I suggest surgery. But I tell the patient the line of treatment on day one itself. When they come back, come to my outpatient department, I say, this is your problem. So this is the line of treatment available. I'm starting the first line of treatment like analgesics and physiotherapy. So we can try at least up to 3 months time. Many patients will become all right. Up to 80% will become all right. Then I say that if don't improve, then I can try an injection. The last option only will be the surgery. So I already counseled the patient on the day one. So when the patient comes to next time, even they are not happy with the pain relief, then they know already that already it was told by a surgeon, by you or me, so that patient will not get disappointed. So always make sure that when you see the patient on the first time, explain about the problem, you counsel the patient, the line of treatment available, everything. Because if you say on day one that I'm going to give an analgesic and physio, and if they come back after 3 months, no, if he's not happy with the pain, you say that, okay, I'm going to give an injection, then you will not be happy. You know, if I told already injection, or if you already
They're,
told
they're
surgery,
mentally prepared.
he'll be prepared mentally,
Yeah.
and you don't need to talk to them too much. The first day talk, everything is over.
Yeah.
So that is how you have to approach the patient.
Yeah.
And this partial cuff or small size cuff tears have to be dealt in a proper manner only. Otherwise, they are quite unhappy patients.
Yeah.
Any role of PRP? Anyone
Sundar,
giving?
one question. Sundar, are you saying that full thickness tears, 80% of them will get better over a period of time? Because my experience is not the same. With full thickness tears, it's a much less proportion of cases who get better with conservative management. And second, there is a logistical problem is you lose a lot of these patients and they never come back in 3 months. They come back after a year and a half with now a much bigger tear with muscle atrophy, Goutillier 2, 3. So there are other issues, but I am not sure that 80% of those with full thickness tear, over a period of time, I have become a bit more aggressive in operating on full thickness tears.
Yeah, I agree. I mean, the completely full thick. I mean, what I told about 80% is more for the partial.
Partial tear. He was talking of partial tear.
Yeah, for the full tear. No, I thought it's a partial tear. So I talked about the partial tear, 80%. This thing. If it is a full tear, I mean, I also tell about the progression of the tear. What she mentioned about that percentage of that patients can go for a complete tear with retraction. I usually counsel the patient, especially in the pretty young patients. I do advise surgery.
Dr. Vishal, is there any role of PRP there in UK
just
regarding?
just 1 minute, Mukesh, just 1 minute, just to answer the question of Dr. Vishal, because just to complete this answer,
okay,
the full thickness here and partial this part Sundar is telling is completely true, and we have to follow and tell the juniors that full thickness tears, you better discuss everything, because this will definitely progress over a period of time. And you have to be very cautious, because once you tell, no, I am going to treat it conservatively, then your follow-up should be very, very meticulous. Because if you tell him that at the end of 2 years, no, I am going to do for the surgery, then probably there will be much of retraction, also the fatty infiltration. So the patient will be an unhappy patient. So I think Sundar tried to mention on the partial cuff.
Yes.
Another point I add on to Dr. Bissal's question is that if you have a complete cuff tear, even in some people, they get better only because if we believe in the cable theory of Steve Barker. Because if it is beyond the cable, then probably they might be having the good force couple and they'll be better by your physio. But if it is beyond the cable, there is no point then this guy will be better. This will progress 100% and he will need surgery. If the guy is more young, it is more true.
Yeah, it depends upon the retraction. Also.
Yes, Mukesh.
It depends on even the full thickness tear. If it is retracted like more than 1 centimeter, I think that cases are all totally different than that full thickness tear which is reported by MRI, but not retracted, just in the footprint. So that is totally different. If it is retracted to 1 centimeter in young patients like this kind of 40 years old, definitely I advise surgery too.
There's another thing about partial thickness tears I have noticed in the last few years, and that's why, and one of my close friends who's a prolific arthroscopic surgeon here as well, does more than 15, 20 arthroscopies of shoulder in a week. We both noticed that a lot of partial thickness tears nowadays we are seeing from the articular side, the cuff looks beautiful, absolutely normal. You go from the bursal side, 80 or 90% of it is peeled off. And that is very important to recognize. And that I am recognizing more in the last 3-4 years. And we've had a discussion, and I'm sure I must have missed a lot of these prior to that.
Are they more athletes or what kind of patients?
No, they are normal people. Even housewives I've seen. From articular side, it looks absolutely beautiful. You don't even want to look from the, you just want to go into the subacromial space, do an acromioplasty and come out. But now I go there, I remove all the bursa, have a look, take pictures, go from the side. And in many of them, I'm seeing 80% cuff tear. It's almost completely peeled off from the footprint.
It's because of the external issues of
the
impingement you are talking about?
beauty of the bursal site. Yes, beauty
Sorry?
of the bursal site tear is that the bursal site tears, partial cuff tears are more painful than the articular ones.
Yeah.
So you will just clinically, if you are very vigilant, you will be picking up more than the articular ones.
Yes, in Indian and even in
Am I correct, Sundar?
Asian population, bursal tears are far more common, and we must able to see them from the subacromial space. And most of them are because of the big acromial spur or because of the osteophytes from the acromioclavicular joint. So these are quite common in our Indian population also.
Yes. Any other case presentation there, Jagtap?
Yeah, Rohan is there. Rohan is presenting.
Rohan is there. No? Okay.
Yeah. Rohan, please.
Rohan, can you go ahead with the one?
Yes, surely, sir. Good evening, everyone.
Share your screen, Rohan.
Yes, sir. Just give me one moment.
Yeah, Dr. Rohan Bansal is a young arthroscopic surgeon from Nagpur, doing good amount of work. He is attached to Kingsway Hospital, newly formed, very big hospital.
How many arthroscopic surgeons in Nagpur?
Too many.
Around 50 or so.
Oh my God.
Satish?
Maybe more than 20, I don't know, 50.
Okay.
No, arthroscopic, not orthopedic surgeons.
No, orthopedic surgeons are more than 300, I think.
Oh
Arthroscopic surgeons maybe around Satish?
25.
25.
Are you able to see my screen?
Yeah. Case cuff tear.
So, thank you everyone for this opportunity. And I would also like to say this was an excellent learning curve over the last 2 weeks for me also. Today, I will be presenting a case of a cuff tear. She's a 44 years female, a diabetic, who was having pain in the right shoulder, the dominant side, for the last 2 years, which has aggravated for the last 3 months. No specific history of trauma per se. She had an inability to lift the right shoulder. On examination, she had a positive belly press and a positive Hornblower's test, along with a weak external rotation. The empty can and a drop arm sign were also positive for her. This is a pre-op radiograph for the patient, demonstrating that the acromiohumeral distance was reduced, along with the proximal migration of the humeral head, along with the acromial osteophyte. The pre-op MRI of the patient demonstrating a complete tear of the supraspinatus and the infraspinatus, as can be seen on these images, and a subscapulary tear on the axial cuts. I'm afraid I couldn't find the coronal cuts for the patient in my collection, but it was a Gotelier stage 2 on MRI. The diagnosis was a complete massive rotator cuff tear with a tear of the supra, infra, and the subscapularis. So we did the arthroscopic diagnostic arthroscopy for the patient, which demonstrated a type 3 Lafosse subscap tear, along with biceps tendinitis. We did a biceps tenotomy and then a tenodesis with the same subscap anchor, which was used for the repair of the subscap. So this is gradually we mobilized the subscap. We did the anterior and the release, the anterior and the posterior releases. We used a single anchor because of the cost constraints for this patient. Did the subscap repair from the intra-articular side. The biceps was tenosis in the same anchor, in a east to west and a north to south repair. Then we entered the then we entered the subacromial space, in which we found that the supra and the infra were retracted up to almost the glenoid margin. We did a gradual release of the supra and the infra, the superior and the inferior releases of the capsule, gradually mobilized the cuff. We did the acromioplasty initially so as to have some space for the retracted cuff to be brought to the footprint. After mobilizing the cuff, we used 3 double-loaded suture anchors for repairing the supra and the infraspinatus back to the footprint in a single row cuff repair. The cuff repair was also medialized so as to decrease the tension on the cuff repair. So this is a nice mobility of the cuff, with the cuff only getting reduced till the glenoid margin, till the humeral head margin, the GT footprint on the medial side. The anchors were passed, the anterior anchor. Actually, I didn't have triple loaded anchor on that day, so I had to use 3 double loaded anchors for the same repair, just to take multiple bites on the same cuff. The knots going on, and just to make sure that the acromial was completely excised with the acromioplasty later on. And this is the final picture of the repair. And this is the post-op radiograph of the patient. The post-op range of motion after around 9 to 10 months when she came for the follow-up. And the post-op lift-off test appearing to be negative. Please. So this is the Lafosse classification of subscap test. Type 1 being the partial thickness tear of the superior third of the subscapularis. Type 2 complete tear of the superior third of the subscap tendon. Type 3 complete tear of the superior 2/3 of the subscap tendon. Type 4 complete tear of the subscap with tendon retraction and concentric joint. And type 5 a complete tear of the subscap with eccentric joint. Hello? Hello?
Yeah,
Yes, Ron.
Ron, you have finished?
Yeah.
You unshare the screen.
Yeah, just one sec. Yeah.
Nice video. Yeah, Ron. Good case. Any questions?
Question from anybody?
Sir, I think the cuff was not mobilized properly and his bites were too much lateral. So I think there is high chances of cutout. So those bites which Rohan has taken should have been more medial than lateral, near that musculotendinous junction. They were too much lateral into the cuff tissue. That's what I think. I don't know. His interarticular.
So the cuff, so it was almost a completely retracted tear in the glenoid margin.
Okay.
So to mobilize the cuff, it was, I would say, only that much cuff mobility was possible.
Yes.
And since this was a young lady of 44 years, so we were planning for a cuff repair only for on that day.
Yes, yes.
Okay.
What Satish is trying to tell, put biceps there.
Yeah, surely, sir. So that's the reason I told you,
that's
sir.
the
Probably
ideal
next time
case
I would
to
use the
put a
biceps
biceps
also
there. Yes, yes.
No, I am just
Just
saying that
really.
his bites were too
Bites
lateral.
are too lateral. Okay, okay. But I hope it is he already has a follow-up of more than 6 months, I think.
Yes, yes.
I think it was follow-up almost 9 to 10 months.
So the cuff is hopefully healed by now.
Yes, by that time, yes.
Yeah, by that time, and it is having a good function. A good case.
Anyone doing corecoplasty for subscap repair? Because
Yes,
I have not done in any of my cases so far.
Yeah, I do it in 2 to 3 cases if the subscap is too far retracted and found that the space between that subscapular space is too much less.
My
I
question
do a
is,
minimum
Satish, how you decide how much space? Because the shoulder is moving. If you put it little posteriorly,
Nah, I use a burr to assess that space. If that burr can be passed very easily between the coracoid and the subscap, then I don't do coracoplasty. But I find that that space is too tight that even a 4 mm burr cannot be passed between that space. I do coracoplasty.
I think 6 mm is the cutoff.
Yeah.
Is it 6 mm?
6 is the cutoff line.
Yeah, 6 is the cutoff.
6 is the cutoff line. Even if you go to your radiology guy who can go to the console, they can measure it properly. What is it? What is it? This is the two ways. Pre-op you can do, and this is the best method. I agree completely with Satish that if you can pass the 5.5 bar between the subscap and the coracoid, there is no need of doing it.
So my question is ki, whenever we are in lateral position and forward elevation, and then whenever you want to do subscap, you ask your assistant to give some posterior pull to the proximal humerus.
Yeah.
So how you decide? Easily the shaver will go off easily. So anything you decide pre-operatively, ki, yes, I'm going to do coracoplasty, or intra-op decision it is?
No, pre-op is most important. If go to your next time you go talk to the guy, he will be definitely giving you the exact your distance between the subscap and the coracoid tip. So that is recommended. There are lot many papers are also there for this coraco subscap in the clear space between the subscap and the coracoid.
Correct.
Yes.
And because whenever I think Mukesh is referring to the way how the subscap is done, because Steve Barker told us that is a specific lever push mechanism.
Yeah,
because
yeah.
the shoulder goes back and the comes front. So that is the best way of doing the subscap with the lever push.
Yeah.
I think we are all done. I will request one of my senior faculty.
I have a very small, with your permission, I have a very small case, very atypical case, less than 5 minutes.
Okay, no problem.
Yeah. It is a rare case with a small social message. Just let me see if I can share the screen.
Okay. Go ahead, Satyajit.
It will be not more than 5 minutes.
Okay.
It's visible, sir.
We all are discussing. I want to know our Nepal friends. No questions are coming from their side.
We are learning a lot, Mukesh. There are a few questions, but that has been common question has been tackled.
I think Mukesh, it is already late, and this is just a rare case of paraplegic lady with a rotator cuff tear. So I will not take much of your time, and she had classical supra and infraspinatus. I think, are you listening? Can you hear me?
It's very well audible. Go ahead, sir.
And visible
so this was a supra and infraspinatus tear. I will maybe I can skip the video. It was repaired in a classical double row method, and we could get a nice repair there, and this was the type of repair which I could get, and very nice function. She is a very brave lady. She didn't stop at her paraplegia. She's doing some work. She's doing running library. She's taking cooking classes, and I am very happy that I am part of her recovery process. So just a social message that you should not stop your good work. And a single slide on review of literature, that because there is a almost tenfold high risk of damage to the rotator cuff in paraplegic. That was one of JBJ's article in 2010. The other risk factors are the age. It increases almost 11% per year the chances of rotator cuff. Females are at a higher risk, more than double. The duration of the spinal cord injury, with every 6 year injury, she had a almost 20 years old injury. So it was very high. Wheelchair sports, if you are going into wheelchair sports, then also the chances increase, though it is very good psychological and physiology for the patient, but definitely cuff tear increases. If there is thoracic hyperkyphosis, then again the posture and all those things, they contribute to increase in the injury pattern. This was mentioned by two of the recent articles. And also the demographic and morphological features indicate that bilateral are more common, which underlines the theory of wear and tear pattern of these rotator cuff tears. So I think I will close down.
Was a nice information to see that literature review, how common the cuff tear in paraplegic.
Cuff tear are very common, and
Yes,
it is
yes.
just a wear and tear. Any experience of cuff tear in paraplegic?
Yeah.
Anybody?
I have a huge experience because Southport, where I started my first consultant job in the NHS in UK, has got a very famous Southport Spinal Injury Center. It's England's prime Northwest Center. So I was the official shoulder surgeon for all the paraplegics from the south, and these are young chaps mainly, a lot of them, and they play a lot of basketball. Wheelchair basketball. So so I have been very aggressive in repairing their cuff tears, and I've got quite a big series. But I agree with everything you said, that basically recognize it early and fix it early. I wouldn't treat full thickness tears in these patients conservatively at all, because that's their upper limbs are their lower limbs also. You know, they use them to propagate themselves and everything. So you don't have the luxury of conservative treatment in them. So that's the only message I got.
Yeah. Okay. Thank you.
Thank you.
Thank you, everybody. And lastly, I would like to ask our presidents from Nepal and Nagpur to give the closing comments.
Yeah, Nepal president, I think.
Yes, I think Dr. Ishwar, you are being the senior most here from there. You please give your comments on today's program.
Okay, thank you, Dr. Samantha. I mean, last 2 weeks it was a very good learning experience. I thank the Indian Arthroscopy Society and the Arthroscopic Society of Nagpur for taking us along for a very nice, very interactive, very well elucidated talks, from which I feel we all learn, and mostly all of us from Nepal have also learned quite a lot. And thank you for making us a partner on this learning experience. I hope also in the future that we can always, carry on forward for this kind of interaction, and we can be more participant. With that, I want to thank Indian Arthroscopy Society and the Arthroscopic Society of Nagpur. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you.
Your comments, Jagtar.
No, I think everything is.
He's a very good friend of mine, and really very close each other. So, Jagtar, point, please.
Yeah, sure. I think everything has been talked about, and thank you everybody, all the participants, all the speakers, and of course Amit, Sandeep, Biraris, and of course Vishal. Thank you.
Thank you.
Thank you for everybody, all the speakers. Very nice. Okay, take care. Goodbye.
Goodbye.
Thank you.
Okay.
Stopping the live feeds.
Special thanks to Sandeep and Sandeep, because they are the backbone of the Indian arthroscopy webinars. Unless these two people, nothing was possible. They are the backbones of the whatever scientific meetings we are doing.
Exactly.
This was a record meeting, sort of. Today we reached the Nelson figure, 111.
Yeah. Yeah, very nice. Congratulations.
Okay. Pradeep,
thank you very much.